Morning. My name is Katie Almond, and I'm the co-chair of the Provincial Human Services and Justice Coordinating Committee. Along with my fellow co-chair, Sarah Diaz, I am delighted to welcome you to the Police Hospital Transitions Provincial Education Forum. Today's forum is the culmination of years of hard work by many talented and passionate professionals from across the human services and justice sectors, all dedicated to better outcomes for persons experiencing a mental health or addictions-related crisis.
We're very pleased that so many leaders from Ontario's hospitals, police services and police boards have joined us here today to mark the release of the Police Hospital Transition Framework and Toolkit, tools that provide a roadmap for police services and hospitals across the province to establish effective transition protocols. We invite you all to access these two resources and use them to develop your own police hospital transition protocols, which can be found online at the hsjcc.on.ca website. Today, in addition to learning more about this new framework and toolkit, we'll hear about the client's perspective, experiencing these transitions, lessons learned from implementing police hospital transition protocols in communities across the province, and key considerations we need to make when doing so.
Before we begin the day, however, we'd like to provide a little background as to how we got here. As I mentioned before, Sarah and I co-chair the Provincial Human Services and Justice Coordinating Committee, one part of a wider Human Services and Justice Coordinating Committee network, or HSJCC for short. The HSJCC network is an intersectoral, interministerial collaborative consisting of over 1,500 professionals from across the human services and justice fields who meet at tables across the province to find solutions for specialized groups of clients who are or at risk of becoming criminalized. Many of our clients have complex needs, including those with mental health or addictions issues, developmental disabilities, fetal alcohol spectrum disorder, or acquired brain injuries.
Members of the HSJCC network, including persons with lived experience, police officers, and healthcare providers, have long been concerned with issues stemming from the transfer of care for those individuals who are experiencing a mental health or addictions-related crisis, apprehended under the Mental Health Act and brought to medical facilities for assessment and care. Since 2012, the provincial HSJCC has been examining these issues and working to identify innovative, effective approaches at the local level that could be adopted into a province-wide framework.
Building on this work, in 2015, the Provincial HSJCC partnered with the Ministry of Health and Long-Term Care, the Ministry of the Solicitor General, Canadian Mental Health Association Ontario, the Ontario Hospital Association, Ontario Associations of Chiefs of Police, and with dozens of justice and healthcare stakeholders to form the Police Hospital Transition Task Force. It is our task force that worked so hard to develop the framework and toolkit to improve police hospital transitions across Ontario. We are extremely thankful for the efforts and dedication of all those involved in this work to get us where we are today. We are delighted to welcome Ms. Robin Martin, Parliamentary Assistant to the Minister of Health and Long-Term Care, and the Honourable Sylvia Jones, Solicitor General of Ontario, to our forum today. This framework and toolkit would not have been possible without your leadership and the support of many of your ministry staff, some of who are in attendance today.
We are also pleased to welcome and thank our major partners on this forum of the Police Hospital Transition Framework and Toolkit. Thank you to Chief Kimberly Greenwood of the Barrie Police Service and President of the Ontario Association of Chiefs of Police. The OACP staff and its members have been a valuable partner on this work, and we are thankful for their efforts and attendance here today.
Welcome and thank you to Mr. Anthony Dale, President and CEO of the Ontario Hospital Association. Staff and members of the OHA have been crucial to the development of this forum and our framework and toolkit, and we are very thankful for your support. And of course, a special thank you to the staff of Unity Health Toronto and St. Michael's Hospital for hosting us all here today.
Our final thank you and welcome is to the Canadian Mental Health Association Ontario Division, who was another major invaluable partner on this work. We are tremendously appreciative and pleased to welcome the CEO of CMHA Ontario, Camille Quenneville. Prior to joining CMHA Ontario, Camille channeled her passion for mental health care and senior leadership roles in the education, governmental and children's mental health sectors. She has also served as the Director of Policy and Communications at Children's Mental Health Ontario, Chief of Staff of Ontario's First Minister of Children and Youth Services, and Director of Policy at the Ontario Public School Boards Association. I would like to invite her to the stage now introduce our first speaker of the day.
Thank you. I am so excited to be here today. This is actually happening. Look at the smile on Upala's face. This has been so many years in the making. We are both kind of pinching ourselves. Here we are. So thank you all for being here. Thank you to our extraordinary partners in this work. We are immensely proud of this. And like all of you, I think we know very well the importance of this framework and the toolkit for all Ontarians experiencing a mental health related crisis and the police services and healthcare professionals who will support them. So thank you, thank you. I have a great job today. I'm so excited to be able to do this. This is, I have to tell you, the third time in 3 weeks that I have been introducing a senior cabinet minister. I think that speaks to the importance with which this government holds the mental health and addictions file. They have been exceptionally activist since they've been elected. We never really believed necessarily this would come to fruition, so you can imagine how excited we are to be here today. Just last week, they announced a Center of Excellence in mental health and addictions, which was tremendously exciting for all of us in the field. And I'm immensely pleased and proud to be here to be able to introduce, first off, Robin Martin, the Parliamentary Assistant to the Minister of Health and Long-Term Care. Ms. Martin is a very activist parliamentary assistant. I know that the minister relies on her a great deal because they have been so active in this file, but also because she is so very knowledgeable. So it's a pleasure to have her with us here today. She has been extremely supportive of this work that we have done. She has been very involved in ensuring that it came to fruition. So it's a great honor to have her. Last night I was reviewing her bio and it came to me immediately because I've done this so many times, because she's spoken out on so many events and I've had the pleasure of introducing her. She's a graduate of both the University of Toronto and McGill University. She practiced litigation before going into public policy and eventually into public office. And without further ado, I will ask Robin if she would join me here. Thank you.
Good morning, everybody, and thank you, Camille, for that kind introduction. As you know, Minister Christine Elliott was supposed to be here today, so I'm bringing her apologies to you. Unfortunately, she had a slip and fall about a week ago, and on doctor's orders, she's supposed to take it easy, but we expect her back anytime. There's no ongoing issue. We just think she should rest a little bit. So unfortunately, you'll have to make do with me. But I really appreciate being here, and I want to say on behalf of Minister Elliott and Minister Jones, we're really excited about the police hospital transitions provincial education forum that you guys are having here today. And we want to thank the Canadian Mental Health Association, the Ontario Hospital Association, Ontario Association of Chiefs of Police, and the Human Services and Justice Coordinating Committee for the incredible work that went into developing this framework and the tools that better support a transition experience for patients in crisis. The framework that you'll be learning more about today is a great example of how collaboration across sectors can greatly benefit Ontarians. In emergency rooms, as you know, across the province, patients brought in under the Mental Health Act must be restrained with police supervision until the hospital assumes custody of the individual. And when there are delays for mental health services, this can create more distress and unfortunately perpetuates the stigma around mental health. It is a significant concern for the police officer and for the hospital. So we applaud this collaborative effort to improve transitioning patients experiencing a mental health crisis. And we applaud your commitment to providing better care for Ontarians. And this is the kind of approach that we want to see evolve as part of our integrated teams in a fully connected teamwork kind of approach across all sectors. So our government is working to develop innovative solutions just like this as part of our overall mental health and addiction strategy. And as Camille noted last week, we introduced the Foundations for Protecting and Promoting Mental Health and Addictions Services Act. And one of the things it does is establish this Centre of Excellence for Mental Health and Addictions under Ontario Health, which is our new single agency. The goal of this new centre will be to standardize the quality and the delivery of mental health and addiction services across the province and to provide a better and more consistent patient experience. You may recall that our government has committed to investing $3.8 billion over 10 years to implement and develop a comprehensive and connected mental health and addiction system, and we're working hard on that. We're going to continue to work toward creating the kind of Ontario where everyone is fully supported in their journey to mental health and wellness. And together, I think we will make our healthcare system and our mental health and addiction services more inclusive and accessible to everyone. So thank you for inviting me here today, and I hope you have a great day. Thank you.
Bravo, and thank you, Robin. It's now my great honor to introduce our Solicitor General, Sylvia Jones. Very early on in the tenure of this government, I had the pleasure of sitting down with Minister Jones and Minister Elliott, along with a number of folks that are in this room today, Chief Perry, my colleague Upala, and we talked to them about this work, and we talked to them about the importance of seeing it through to fruition and how very passionately the group that had come together to do this work believed in it. And at the end of the meeting, when the two cabinet ministers left the room, I turned to Upala and we were talking about how we thought that seemed to resonate. And I could tell with Minister Jones that the wheels were turning and she was going to be quite determined to see this through. So it is with great pleasure that she is here today, that she's with us on this important day. Just by way of background, she was elected in 2007 in the riding of Dufferin-Caledon. And she, as I say, is obviously Ontario's Solicitor General. So without further ado, I'll ask you to join us, Minister Jones. Thank you.
Thanks so much. You know, in 2007, there was an opposition member named Christine Elliott who formed the idea of having a select committee to study mental health and addictions across Ontario. And I was a brand new MPP at the time, and I spoke to the powers that be and I said, how can I get on that committee? Because when I speak to families in my community, I can't get access to service. and I want to be part of this. And so many, many, many years later, there is a certain pride in ownership that now Christine Elliott, as the Minister of Health, and myself are able to facilitate what has frankly already been happening since 2012. You know, we often talk about silos in government, how different ministries won't talk to each other, won't work together. And I am struck as I saw the work that has been done and the briefing that we had, how you have been able to break down those silos. So to the committee members, thank you for having the commitment to get this done. It is critically important on both the policing side, but also on the individuals who are seeking assistance and needing assistance. And what did I say, 10 plus years later, the fact that we are today talking about protocols and actually looking at best practices that have been working and able to share those with other police services and other hospitals across the province is very exciting news for us. You know, we get a lot of, how shall I say this? We get a lot of ink on our government's desire to get the books back in order. But what I am driven by is we are also spending a lot of time making targeted investments that are really, truly going to make a difference in the lives of people across Ontario. And to me, while this will never be at the front page of any newspaper, unless we're lucky, this is a game changer for individuals who are seeking treatment, for police officers who should be out assisting people instead of sitting in an emergency room. And so I am very thankful for the work since 2012, I think it was, when it began. And I'm very pleased on behalf of Minister Christine Elliott and myself to congratulate you and move forward and finally get this done. All the best.
I was reminded to give a shout out to those of you who are online and are listening and watching. Thanks very much for joining us. Thank you, Minister Jones, for your remarks and for joining us here today. And thank you as well to your ministry for its work in supporting the development of the Police Hospital Transition Framework and Toolkit. It is now my pleasure to introduce our next speaker, Jennifer Chambers. Jennifer is Executive Director of the Empowerment Council, which represents the voice of clients at the Centre for Addiction and Mental Health. She developed the Queen Street Patients Council in 1992 and the Empowerment Council at CAMH 10 years later. On behalf of both organizations, Jennifer facilitated the first legal intervention and subsequent interventions by mental health and addictions clients in charter cases before the Supreme Court of Canada, and the first and subsequent acquisition of standing at an inquest in Ontario for the same community. Please join me in thanking Jennifer for bringing her important voice to our forum and welcoming her to the stage.
Hi, a little bit scary up here. Being brought to the hospital by police is often frightening, usually humiliating, and can be infuriating. Think about the worst day you've ever had, then imagine that happening publicly while you sit handcuffed in a waiting room with all eyes openly or surreptitiously upon you, judging you, thinking you must be crazy and criminal. For some people, this is preferable to life on the streets or lonely desperation, but why should care for people in distress be such a low bar? You may wonder why people with mental health and substance use issues so often end up in emergency departments. We wondered that too, so the Empowerment Council partnered with Lori Ross and others to answer that question in a study called Barriers and Facilitators to Primary Care for People with Mental Health and Substance Use Issues. A couple of samples of what people said. Arlene, age 54, if you go to your family doctor about substance use, unless he's very open-minded, you'll be shamed. If you go to a walk-in clinic and mention it, they'll call you drug-seeking. Provider prejudice was particularly problematic for participants with substance use issues, but many people who reported mental health issues only also reported barriers. Lynette, age 34, described this exchange. I said I have dissociative identity disorder, and she, the healthcare provider, said, "What's that?" I told her, and she stopped the interview right there and said, "We don't deal with people like you here." So I just left and started crying and walked home.
People who self-harm are often badly treated in emergency departments where they're told they're taking time away from people who have real problems that they didn't create themselves. I'm telling you this because when I talk with police, orienting them to how people in crisis might feel about going to the hospital, I tell them that while offering to take someone to a hospital can be kindly meant, people have many different feelings about it. These feelings might be rooted in experience, or they might be rooted in the fear of social prejudice, because prejudice is something that everybody's raised with and often share, even if it results in internalized oppression. Edmund Yu, for example, who was shot in a police car, was offered a hospital, and this well-intended offer was intended to reduce tension, but because he's somebody who had terrible side effects from neuroleptic medication, it might very well have escalated it. Sadly, when people need help, they have few options. A person or other people might call 911 because someone's on the edge and they want police to keep them safe. Or they might think if the police bring them to emergency, they'll be taken more seriously and not turned away, though this is not always the case. Which can be a result of callousness, but it's got more to do with not enough resources and having the unfortunate job of ranking risk with those few resources available. How people feel when they get to the hospital depends a lot on how it went with police while getting there. Compassion without condescension means a lot. One person told me that when he was being transported by 3 officers, one rolled his eyes and said, "We get all the nuts." The second one agreed. The third one said, "Never mind them, they don't understand." That mattered so much to him. He said it was the one tiny hint he had at that point that the world might not only be awful. Another person talked about being told to stop singing while being transported. He said, "Maybe I wasn't the greatest singer, but it was helping me. And was it really so hard to just let me sing for a little while?" We've asked the Toronto Police Service and Mobile Crisis Intervention Team not to handcuff people unless violence is a real issue. Being treated like a criminal is devastating, and this comes at what's already a low point in somebody's life. Police don't like to wait, I mean, who does? But hospitals rarely have doctors available quickly for an assessment. So other alternatives are being used, some of questionable legality. Someone I care about was taken from police given by police to hospital security and put in a room by himself all weekend without seeing a doctor, without being assessed. By Monday, he was furious and they released him and apologized, so he left worse than when he arrived. People have described being left alone in the room by themselves for many hours, watched over by security and not allowed to leave, but not assessed. This must not be permitted. If someone's not in police custody and not on a form, they're free to go. And incidentally, also, if a hospital works out an arrangement with police for a quick transition, people still need to go to the hospitals where they're most familiar and most comfortable. It doesn't pay the hospital back very well for working out a speedy transition if all the patients are then taken to that particular hospital. If people are treated harshly, it's ultimately going to be harder for everyone involved. And even if the effect doesn't show this time, if there's another time, then it'll be worse for everyone. What people need is respectful care and connection and help getting their self-identified needs met. Sometimes there are burning desires to be left alone, but that's not always an option. There are many opportunities for kindness. Some police have been sympathetic about people's lack of privacy in emergency rooms and have tried to shield them from being seen. Emergency room staff have asked for handcuffs to be taken off of people who are more upset by that than anything else. It's still unlikely to be a good moment in someone's life, but it can be a less bad moment. Other suggestions from people with lived experience: give people food and drink, or at least a snack, who are there for a long time if they have no money, can't leave, or if there's no other way to get real food. There's a reason for the expression hangry, perfectly natural response. Regularly explain what's going on. Don't talk about people as if they're not there. If someone's in restraints or seclusion, explain what needs to happen for them to be released. If someone's chemically restrained, explain everything about it as if they're getting informed consent. If a person seems out of it, keep in mind that they'll often remember everything that's said later. Police should not be the only ones available to attend people in crises 24/7. Hospital emergencies should not be where people are taken because they're having a really hard time or giving other people a hard time. We need peer-run, community-based crisis services that are responsive to people's self-identified needs 24/7 and basic necessities of life like housing. Why isn't that supported instead of the popularity of forcing unwanted services on people? Attend to the needs that people want help with, then see if any needs remain. Years ago, there was a study in Brockville conducted by Hugh Lefebvre People who were in and out of the hospital were divided into 3 groups. One remained the same, one was simply given more money, one was given more money and the opportunity to call for supports whenever they needed it. The initial group, the first group of course stayed the same, the second group considerably cut back on the use of hospital services, and the third group cut back the most of all. So this initiative can actually have the potential to save millions of dollars because hospital days are the most expensive type of care that can be provided. Sadly, what we got instead of that was throughout the province was less effective and police-involved coercive community care. Big change is probably not going to happen anytime soon, in part because there's so many powerful vested interests in the current dysfunctional system. But significant changes can be made by, for example, investing in peer support services like Sound Times, which offers an array of options for people with mental health issues and justice, in touch with the justice system as well, and creating more non-medical model community-based crisis services like the Gerstein Centre in Toronto. When hospitals are used, have peer support available in emergency rooms offered by local peer support services like PEP in North Bay. All of these options are more cost-effective and humane than an over-reliance on hospitals and police. And I know many hospital workers and police agree with this. And finally, support an independent peer-run voice at every hospital in order to get real ongoing feedback about processes such as these. Best evidence clearly shows that advisors selected by hospitals or peers in the employ of hospitals are not in a good position to give real fulsome information about people's collective experience, especially if it's a critique. Sadly, this is exactly why many hospitals have chosen this model. The government also needs to include the voice of peer-run organizations at every table about decision-making in mental health and addictions. This is governance with the people. This is how sensible decisions are made. It's ironic, the irrational decision-making that's created a system to control people considered irrational. Thank you.
Thank you so much, Jennifer, for your remarks and providing a key perspective on the issues we're working to address here today. I'd now like to welcome to the stage the co-chairs of the task force that developed the Police Hospital Transition Framework and Toolkit to provide us with an overview of the document. By leading the task force, Chief John Perry and Upala Chandrasekera, I hope I didn't butcher that, have been tireless advocates for improving police hospital transitions across the province, and we owe them many thanks for ensuring we have these resources to bring back to our communities. Chief John Perry commenced his career in policing in LaSalle in 1987. He is a 30-year veteran of the London Police Service. He was appointed Deputy Chief in 2012 and Chief of Police in May of 2015. Chief Perry is Vice President of the Ontario Association of Chiefs of Police, Chair of the John Howard Society of London and District, and a member of the Board of Directors of the Canadian Mental Health Association, Ontario. He has received numerous awards, including the Police Exemplary Service Medal and the Queen Elizabeth II Diamond Jubilee Medal. In March of 2015, he was named a member of the Order of the Police Forces by His Excellency, the Right Honourable David Johnston, Governor-General of Canada. Upala is a social worker with over 15 years of work experience in the health sector, ranging from frontline work assisting individuals and families with mental health and addiction issues, to supporting mental health programming province-wide, and implementing the national strategy to address mental health across Canada. Currently, Upala is the Director of Public Policy at the Canadian Mental Health Association, Ontario. She provides strategic policy advice to the Provincial Human Services and Justice Coordinating Committee. And from 2012 to 2018, Upala served on the Board of Directors of the Mental Health Commission of Canada. In 2017, she was appointed to the Toronto Police Services Board, the first ever mental health professional to be appointed to this role. Please join me in welcoming John and Upala to the stage.
Great. Well, good morning, and I just wanted to take the opportunity to thank everyone for being here, joining us online for this very important announcement. As been said, in January 2016, a task force was created to create a framework or an action plan to help Ontario communities improve police hospital transitions. And I wanted, on behalf of the task force, to take the opportunity to thank Minister Elliott and Minister Jones for their support of both these initiatives. The project engaged stakeholders and persons with lived experience from across sectors to enhance collaboration between Ontario hospitals and police services with the purposes of improving outcomes for individuals experiencing a mental health related crisis that have been apprehended by police officers under the Mental Health Act. Over 30 agencies, in fact 35 individuals, sat around a table as part of this task force. And something that with such a large group that doesn't really happen is we all agreed on what we needed to do in terms of improving these outcomes. So on behalf of UPLA, and I would like to thank our colleagues for their collaboration, their work, and their persistence in developing the framework, one that is a person-centered approach and provides key ingredients of an effective police hospital transition protocol. It's got to be an easier way. There we go. There we go. First test to see if I can change the slide. So one of the, I'm going to give more from a policing perspective about the rationale and the reasons that I supported this. And one of the worrying offshoots of deinstitutionalization of mental health services has been a marked increase in the contact between persons with mental health related illness and criminal justice system, that including the police. Compounding those issues, there are other social issues such as homelessness and poverty that have impacted individuals with mental health related illness. Individuals with high needs and high risk complex mental health related illnesses are often not receiving the care and support they need. And the first response to a mental health crisis in the community is often to solicit the support of police. Regardless if these incidents are a formal legal matter, police services are often the first point of contact. And I know that many police services across not only Ontario but across Canada have examined the impact of persons with mental related illness intersecting with police. And the London Police Service has completed 2 studies, the first one in 2001 and the second one in 2010, that specifically examined 3 categories of contact with police. The first one are those individuals who exhibit behavior or symptoms that are not necessarily related to any particular crime, but as a result of their mental health related illness. And we get calls from the individual, from other individuals, or from the officers that are on patrol. The second category included individuals that come into contact with police after the commission of maybe a low-level offense, such as trespassing, liquor license, even some minor criminal offenses. And then the final one, obviously, are individuals that unfortunately commit criminal offenses. In 2001, the study determined that $4.5 million of our police budget was spent addressing all these categories of incidents of persons with mental illness. And by 2010, that had grown to $12 million of the police budget, and estimated in 2016, we'd reached over 17% of our budget was spent specifically addressing those 3 categories. There is also often a misunderstanding that police have access to the mental health system or an easier access to the system. We often get phone calls from family members wanting to use the criminal justice system to get them access to the support and treatment that they need. And I'm a strong believer that the criminal justice system is the wrong way to go and often is relied on some police officers out of frustration by family members and other communities around individuals that are suffering. There has been tremendous work in communities across Ontario to develop effective community mental health and addiction strategies. And these important partnerships have resulted in better strategies to serve individuals in our community and also divert them away from emergency departments. And it's mobile crisis response teams, the integrated police and mental health crisis workers, and the mental health crisis centers, one which is in London and is a tremendous asset for us. Without these partnerships, there are very few options for police to support individuals, and often the circumstances then require the police to apprehend the individual and take him to the emergency department to be examined by a physician. And part of the work that was done by this task force was to look at the Mental Health Act and how this transition protocol could work together. Because when it really comes down to it, all of us that come into contact with individuals with mental health related crisis, police, mental health and addiction service providers, hospital staff, all have to ensure that we deliver effective and coordinated care for the individual in crisis. So upon making the apprehension, police officers with the individual will have to transfer at the hospital. There are a number of service dynamics that occur during this transition process that results in issues that impact police services, hospital staff, and the individual in crisis. And Jennifer has outlined several of the impacts that an individual who's been apprehended by the police and are taken to an emergency department. I can tell you over the course of my career, it was a very uncomfortable position to be sitting there for hours on end with an individual that was suffering and people that were watching them, and quite frankly, the invasion on their privacy, in my perspective, when they were trying to talk to hospital staff and have police officers nearby. The emergency departments, they face a lot of challenges balancing emerging care and then trying to meet the needs of individuals experiencing mental health crisis. But from a policing perspective, we look at what our core mandate, and that is community safety. And often police officers are spending on average between 5 to 8 hours in the emergency department rather than providing services out in their community. Officers are unable to respond to other potentially urgent calls for service, which has an impact on community service or community safety with limited resources. This framework, and you'll see later on, and I think it's included in the package, provides steps or strategies. I'd like to call it the continuum of care for an individual that finds them into crisis. We'll try to address these multiple intersecting issues in a standardized approach that allows for the transition from the hospital or from the police to the hospital quickly as possible, while being mindful of the safety and the impacts to the individual, hospital staff, public, and the police.
Thanks, John. And thanks for outlining all the challenges that police services face during this transition. Throughout the course of our work, we actually spoke extensively to hospital staff as well to understand what are the particular challenges for hospital staff when it comes to police hospital transitions. So one of the key challenges is that upon arriving at the hospital with the client, mental health and addictions crisis situations are not often given a top triage priority. So when we look at the Canadian triage and acuity scale, mental health crisis situations don't score a 1 or 2, they're sometimes a 5. 1 or 2 are when there's a physical trauma and life is in danger. So that's a challenge. Police accompanied visitors face challenges and delays because of the shortage of mental health and inpatient beds at the hospital. We heard Ms. Martin talk about that earlier today. Often also space in the ER is very limited. I think many of you have been to an ER situation. Every single piece of real estate in the ER is spoken for, so it's often challenging to find a quiet space for the police accompanied visitor. And one of the key challenges that we heard is that many hospitals across the province do not have a security department. And as a result, some hospital staff might not feel safe dealing with a high-risk crisis situation. Jennifer talked to us this morning about the challenges that individuals in crisis face. I'm just going to highlight one important thing that happens outside of an urban center like Toronto. So in a lot of rural and northern areas, police often accompany the individual to a non-Schedule I facility. So non-Schedule I hospital does not have the authority to form an individual. So what that means is they're medically cleared at a non-Schedule I and sometimes then transported another 2 or 3 hours away to a Schedule I facility. And so when you think about the officer's time and commitment there, that could take an entire shift if they're going from one hospital to the next. But in terms of the individual, when that person is released from the Schedule I facility, now they're released into a new community, and their home community might be 3 hours away, right? And so we're actually seeing an impact of that on the shelter system because that person is now going into the shelter system in that new community with no way of coming back home. And a local example, Toronto as well, right? If you were picked up in Scarborough and taken to a Scarborough hospital, but you actually live in Etobicoke and you don't have bus fare to come back to Etobicoke. It's not a small distance, right? It's over an hour drive between Scarborough and Etobicoke. So it's these kinds of challenges that really impact individuals in crisis. We also looked at what are the unique impacts on children and youth. And Jennifer talked a lot about stigma. The stigma around sitting in an ER with a police officer, that's huge. That is detrimental to a person's recovery. And when we think about children and youth, there's so many other stakeholders involved, right? Parents, schools, community-based agencies, Children's Aid Society, and a lot of these services are only offered between 9 and 5. And so if something happens, a crisis happens in the evening, children are facing a lot of delays. We also, throughout the course of our work, looked at research, peer-reviewed research studies that show that racialized groups are actually overrepresented in police-accompanied visits to emergency departments. And we see that this in northern rural areas too, in terms of Indigenous communities. And we know that there are a lot of barriers with respect to lack of interpreter services available in the hospital system, and also culturally appropriate services on the policing side and on the hospital side. So again, big challenge. So for our project, we first looked at all the issues impacting police hospital transitions, and we spoke to a lot of police services, as you heard, hospital staffs and clients. And when it came to our project, we did this in 3 phases. So the first phase was started in 2012, and the HSJCC network, we formed a police emergency department working group. And that consisted of very much frontline providers. So frontline police officers, frontline hospital staff, community-based agencies, and we also consulted with clients. And what we started with was a call for information out to the field to say, what are the challenges, issues, but also what are the solutions you have for police hospital transitions in Ontario? And we received over 100 responses. And if I remember correctly, we also received responses from across Canada for this call for information as well, because people were so interested and they'd heard about what we were doing. And within that 100 responses, we actually received 20 written agreements between hospitals and police services across Ontario. And so what we did as a first phase was to develop an information guide around the issues and solutions to police hospital transitions. This info guide is available for free download at hsjcc.on.ca. And what this info guide highlights are some key strategies for improving police hospital transitions. I won't go through all of the strategies with you, but I will tell you that we used a lot of this background research to inform the new framework and toolkit. So the very first thing, the key to effective transitions is a strong relationships between police services and hospitals. And those relationships have to exist not at the very frontline level, not just at the frontline level, but also in terms of middle management, as well as the executive leadership levels. Another thing is providing cross-sectoral training for police services and hospitals. And what we recommend is when you're doing training, doing it together so you have police officers and you have hospital staff in the same room with clients so that you're learning from each other and also challenging each other's assumptions about our roles in the transition. Another key thing that we've come across is using a mental health screener form to communicate information about the circumstances and observations about a person in crisis. And the form that we recommend is the Inter-RI Brief Mental Health Screener. I know that we're going to hear about how the OPP has rolled this out across the province. And this is such an amazing tool because what it does is it allows a police officer to document everything that they're observing about the client at the moment that they decide to make a mental health act apprehension. And this is also the justification, right? They're writing down their justification for why that apprehension was made. And Inter-RI Brief Mental Health Screener is so great because they actually use clinical language. It's very similar to the RI mental health that's used in hospital inpatient system. And so the officer makes their observations, and then when they get to the ER, they actually hand that form over to the nurse in charge. And that, it makes the communication so crystal clear, and that's so important, because as we know, a person's symptoms can change in the course of 2 or 3 hours that they're waiting in the emergency room. And so it's really important that the officer note down the initial observations that cause them to make the apprehension in the first place. Another key piece that we learned throughout our research is the importance of having a written agreement between the hospital service and the police service and the hospital. And that's why we're really here today. We want to give you some guidance about what are some best practices for establishing this written protocol. One thing I think in listening to Jennifer talk about the needs of clients who are in crisis, a key piece of this is how do we engage the client in this process? And a way to do that is crisis planning. How many of you have heard of the Wellness Recovery Action Plan, or WRAP? A few of you. Awesome. So if we put it into legal terms, this is actually an advanced directive. This is when a client can, in moments of wellness, actually plan for moments of illness, where they can identify, this is the person I want to help me. This is where my medications are. This is where I'd like to go. Because Jennifer talked about the importance of, choosing where you want to go for your care. These are the types of things that can help me. And this is the person that you can call if I'm in crisis. And what the WRAP does is actually supports the client to make these decisions before their periods of illness, because we know mental health issues are very episodic in nature, right? You can have lots of periods of wellness surrounded by lots of periods of illness. And some clients actually can carry this on a card and have it in their pocket for moments of illness. So it's these kinds of innovative solutions that we need to also empower the client to take those steps towards their own recovery. So phase 2 of our project, you'll remember, we got 20 written protocols from across the province. So we actually did some analysis on those 20 protocols, and we identified 3 successful protocols. And we also did that by talking extensively to police officers. And I remember actually Katie on the phone with a lot of police officers saying, hey, does this work for you? Why did it work for you? And how did you go about establishing this with your hospital? So the 3 that we held up as exemplary examples, one from an urban center, one from a more medium-sized city, and then one from a more rural area. And as you can see on the slides here, the Hamilton protocol was really what we based our provincial framework on. And you're going to hear a lot more about that during the discussion panel after the break. And so before they implemented their protocol, their wait times were about 2 hours, and after the protocol, it was just over an hour. In Waterloo, again, their protocol, before they implemented it, it was 5 to 8 hours, and afterwards, it was about an hour. And then the Prescott-Russell area, again, 5 to 8 hour wait time, and then after the protocol was implemented, it was less than 2 hours. So phase 3, this is why we're all here today. In terms of the new police hospital transition framework for Ontario, these are the key outcomes that we intend to achieve. Improved outcomes for people experiencing a crisis. Of course, that's foremost number 1, because this is all about the person in crisis, the patient at the center of this care. Number 2, decreasing police officer wait times in the transfer of custody. And really, the optimum goal is to have that wait time be 30 minutes or less. Number 3, enhance collaboration and coordination across hospitals and police services. Number 4, reducing the number of police accompanied visitors altogether, so that we're actually diverting people away from hospital, right? We heard a little bit about this. We're going to hear more during the discussion panels, but there's so many services out in the community that a person can be taken to. The ER doesn't always have to be the only place that you take a person in crisis. Number 4, protecting healthcare worker safety and security using system improvements. This is so important. And parts of this is also about breaking down some myths about what is a typical mental health crisis patient, right? We're going to hear more about that on the discussion panel as well, because majority of the time, these are very low-risk crisis situations. And then number 6, the importance of promoting public safety, because as we've heard already from Solicitor General Jones and from Chief Perry, police officers shouldn't be waiting in the ER. They need to be out on the street ensuring our public safety. In terms of timelines, we struck a task force in 2015. We drafted the framework in early 2016, and we did extensive consultations. And we completed the framework in about towards the end of 2016. And today is the big day, because it's now, I understand, at 9:30 this morning, an all chiefs memo has gone out to all chiefs across the province. As well, a memo has gone out to all hospital CEOs and paramedic chiefs and police board chairs with introducing this new framework. So today is an exciting day. John talked about our task force. This is an incredible group of people. As you can see, so many sectors represented, and there's so many of you here today. Can you just raise your hand? I just want to acknowledge you because you were such an incredible part of this work. Oh, everybody's shy. Thank you. There's a whole bunch of people in here and online as well. So I really want to thank you all, because without your efforts, without your commitment, we would not have achieved this. And in terms of the consultations we did, we spoke to leaders from the mental health and addiction sector. We spoke to the Future of Policing Advisory Committee, or as I call them, the policing gods. And they were so supportive. The Ontario Hospital Association was fantastic. We consulted with many of their councils. We also spoke to patients, so the Ontario Association of Patient Councils. We also spoke to the LIN CEO Council, as well as we held consultations throughout the HSJCC network, as well as in person and online. So this is the framework now available for download in English and in French. I really encourage you to check it out. And there is a sheet in your package that gives you a direct link to where you can find this online. So the purpose of our framework, really to improve the outcomes for individuals apprehended under the Mental Health Act, while respecting individual rights, including the right to privacy, improving transitions between police officers and hospital workers, and improving coordination and collaboration among partners involved in the transition. Intended audiences, as you know, police services and hospital staff. So here is the main part of the framework, which is the key drivers of effective police hospital transitions. And what we learned throughout our years of examining this issue is that the most important piece is to obtain endorsement from the police chief and or the OPP detachment commander and the hospital CEO in your community. Because what we heard is where there was a great relationship between the hospital CEO and the police chief, these protocols work great. But where there wasn't a great relationship or a breakdown in their relationship, this wasn't happening. So it's so important that the hospital CEO and the police chief be the executive sponsors of your protocol, and that it really needs to start at the top. Number two is establishing a police hospital committee. And this can include the executive leadership, but also middle management and frontline workers as well across policing and hospitals. And this is the team that's going to come together, iron out your issues, talk about what works best for your community, because what we're providing you with is a general protocol. It has to be tailored to what works and the resources available in your community. Number three is developing the protocol itself. And what we provide in the framework are some key questions. Some are legal questions, and some are client-focused questions about what you need to consider when you're developing your protocol. And when I say legal questions, we had a lot of legal eyes on this. The Solicitor General's ministry had a legal opinion, Ministry of Health had a legal opinion. We actually had lots of lawyers on our task force, and they were really fun to work with. And so we really thought about all the legal questions that you need to know during this process. The next piece is providing training. Again, I spoke about this earlier. Really important to train police services and hospitals on your particular protocol in your community. And for OPP, that means really you're going to have a variation across the province, because you're involved with so many different hospitals in so many different regions. Number five, implementing the protocol. We're going to hear a lot more on the discussion panel about the effective ways to implement protocol, but this is really that plan, do, study, ask, PDSA cycle. For those of us who are in healthcare in the room, this is really a quality improvement exercise, right? It's because you're really thinking about, what are the ways, how do you make this transition effective using a quality improvement process? And then number six, of course, monitoring the protocol, establishing some benchmarks as we've seen in the three protocols that I showed you already, having a baseline to compare to as you move forward through your process. So that's the high-level framework. The other piece that's important in this initiative is the toolkit that we developed. Again, available in English and French online. I really encourage you to check it out. And what we have in the toolkit are actual resources that you can just pull right out of there and to start developing your protocol. So the tool one I'm going to talk about in a second, the stages of transition. Number two is police hospital committee terms of reference. So our task force, we drafted for you a sample terms of reference that you can just pull out and then tailor to your needs in your community. And again, remember, you need to form the police hospital committee first and go through this together across both organizations. Tool number three, again, a sample protocol that you can use and tailor to your community. Tool number four, this is all the information you need to know about the Inter-Arrive Brief Mental Health Screener. And we're going to hear a lot more about this screener on one of our discussion panels. But again, this is the form that the police officer fills out when they respond to the crisis situation. This is their justification for why the Mental Health Act apprehension has to take place. And then this form is then taken to the hospital and given to the charge nurse, and a copy is then put in the patient's file. It's a really, really wonderful tool. And then number five is the transfer of custody form. And I'm going to talk about this form, again, a really important tool in terms of communicating. I would say the most important thing we did during this process is this stages of a police hospital transition map. This is tool number one. This is in your toolkits. Feel free to take it out. And I'm going to walk you through the different transitions stages. And our task force spent many, many hours discussing this and actually dissecting what happens from the moment a call comes in and a person's in crisis to the moment they're released back out into the community. So let's walk through this a little bit. So stage number one, the individual experiences the crisis. And this is, again, the importance of crisis planning. This is where family members, friends, colleagues, community-based mental health and addictions providers can actually support clients really well by supporting them with a crisis plan for what they want to do when they're in a crisis situation. So that wellness recovery action plan I spoke about, this is a great moment to do that. Number two is when the crisis call is placed. And often, 911 is the first call, but in some communities, there are a lot of resources where 911 doesn't have to be the first call. And we had extensive conversation about this at the task force, and we discuss it at length in the documents too. In some areas, we have mobile crisis intervention teams. So about 2 weeks ago, I had the pleasure of being on an MCIT, which is a partnership in Toronto between St. Michael's Hospital and the Toronto Police Service. And I have to say, I learned so much being on this ride along. I actually got to witness on one of the days I went an apprehension that started from the point of intake, when the call came in, through to how the assessment happened on the front line, through to the escort to the hospital, and then waiting in the hospital. I won't say which hospital we went to, but the entire journey took about 4 hours. And that's just right here in Toronto. The next piece is what happens when the police officer arrives. So we talked a lot about, okay, a mental health act apprehension is made and then someone's taken to the ER. But in some communities, you don't have to take the person to the emergency room. You can take them to another place for assessment and care. So Chief Perry talked about what's happening in London. London, Ontario this is such a great example. Our CMHA Middlesex branch runs a 24-hour crisis center where anyone can go at any time. And when this crisis center opened about 2 to 3 years ago, once people started learning about it, they were self-referring and going themselves. And we know that police are directly taking people to this crisis center. So in that way, we're diverting the emergency room altogether. It's so important. So after the police officer arrives and a decision is made to do a mental health act apprehension, so important to call ahead to the emergency room where you're going and let them know you're coming so that hospital staff have time to prepare for this incoming police accompanied visitor. Number 5 in the transition is when the individual is taken to the emergency department. So communicating upon arrival, this is where that Inter-Arrive Brief Mental Health Screener, this is where you can use that form because it gives all the observations the officer has made directly over to the hospital staff. Having adequate staffing support, of course, so important in emergency rooms, and sometimes we know it's just not possible, right? Resources are limited. Another great recommendation is having a quiet room. And this is a place where the police accompanied visitor with the police officer can be away from the general emergency department. So when I was on the MCIT, there was unfortunately no quiet room for the police accompanied visitor. And this client that we were with, they were it was a great situation. This person came voluntarily, so we didn't actually technically do an apprehension. This person wanted to go to the hospital. They're a very low risk client, very willing, and we arrived in the emergency room and there were so many other people there. And so this person was sitting and waiting with myself, the nurse, but also the police officer. And you start to get looks and you know what people are starting to think about this individual. And that's where the stigma comes into play. But a key thing that happened in this moment was whenever something else happened in the emergency room, whenever the dynamic shifted in the emergency room, if somebody was upset or crying, then our client started to escalate, right? And so this is a key learning in how important it is to have police company visitors away from the general ER and in a more quiet space. Designating a liaison in the ER is important. This is a crisis worker that can help divert people back out into community-based resources. We're going to hear a lot more about that on our panel. And then peer support. Jennifer talked about this so much. The peer support worker role is so key. And this is the person that engages directly with the client, lets them know, what's about to happen in their transition. Also, if there's family members or others that have arrived to support that person in crisis, again, the peer worker is so important. Number 6 is the joint analysis of risk. So this is what makes our protocol for the province so unique. A joint analysis of risk. This is really the moment when the responding officer and the charge nurse have a discussion about the level of risk of the client. And you're not just talking about their risk in terms of are they a threat to themselves or others, but you're actually talking about are they at risk of leaving the hospital? Because if the individual is not at risk of leaving the hospital, they're okay to be there. And legally, we got the legal opinion, they're okay to be there in the emergency room. And so that way, hospital takes over, the police can be on their way. But this conversation is so important because if the client is a low to medium risk, then the officer can leave. But if the client is a high risk, especially of leaving the hospital, then the officer stay. But we also know that symptom-wise, risk can fluctuate, right? So if the risk of the client changes within an hour or 2 hours, then we request that the police prioritize that return call to the emergency room. But this joint conversation about risk is so important. This is what will make the protocol successful. The next piece, phase 7, the examination by a physician. Again, we talked about if you're at a non-Schedule 1 facility, then you'll need to have an addendum to your protocol that talks about how do you then go from the non-Schedule 1 to the Schedule 1 facility in your community. And a lot of the times that might mean partnerships with your paramedics in your region. And then number 8 and 9, either the individual is admitted, so ensuring that their rights are protected. And then number 9, if the individual is released, again, making sure there's a warm handoff to a community-based agency so there isn't this revolving door. That client is actually connected to a community-based service so they don't need to call 911 again, have police arrive and bring them to the emergency room. That's kind of the end. We're happy to take a few questions. Okay, awesome. Well, thanks so much. Oh, Jennifer, you had a comment?
Is the mental health screener available to be seen somewhere?
Yes. So a draft copy of the screener is actually in the package, but it is a copyrighted document, so there's process on how you obtain it. Yeah.
With regard to identifying the low and medium risk of the individuals in the hospital, who's making that determination to assess liability or risk?
Yeah, so the question is for those online, who makes the determination of risks and who accepts liability? That's a great question. So in terms of risk, this is a conversation that needs to happen between the responding officer and the nurse in charge. So they make a joint decision and they actually sign off on the form. And it's about whether it's low risk, medium risk, or high risk, right? And the low risk clients can tend to be the ones who are voluntarily there, who want to be admitted to hospital, which is majority of the case. High risk clients are the situations where the officer has to stay. The medium risk, they have to make the call, you know, based on the situation in that moment of time. No problem.
So just a follow-up to that, I think there was a reference made to Section 33 of the Mental Health Act, where I believe it was stated that the police officer is expected to leave and hold custody until the hospital accepts that. So I get that you can't hit everything bang on, but it seems like a little bit of a gray area.
Yeah, absolutely. This is why we got so many legal opinions. So in terms of what the legislation says, yes, forthwith the officer shall take to the emergency room, and forthwith for an assessment. But we know that's not often possible, right? So this is why this joint analysis of risk is so important, because it's a decision based on what's happening with this particular client in this particular moment to say, okay, what's the level of risk right here that the person's about to leave the hospital? If the risk is low, then the officer can leave. If the risk is high, then the officer has to stay. No problem. Yeah.
Just so you know, I don't think there is a screener in the package.
It's on the online package when you download it. It's in the toolkit. Yeah, it's in the toolkit. Yep, we're here.
With regards to leaving a patient who's maybe a medium risk or a low risk or even a high risk in the hospital, was there any consideration given or any recommendation about the hospitals having their on-site security, if it's available, taking over some of the responsibility there?
So we did have hospital security representation, actually right from St. Michael's Hospital on our task force. And so there was a lot of discussion in that. In terms of managing risk, every hospital has their own way of doing it, right? Even in terms of when you think about a code white, there's different ways in hospitals manage that situation. So it has to be tailored to what's available and the resources available in your community.
The reason I ask is my daughter is a nurse and she's experienced physical attack from somebody who appeared to be low risk, but when the officer left, elevated, and if it wasn't for the on-site security, she's in a big hospital. If it wasn't for the on-site security, there could have been code white or an escalated situation.
Yeah, thank you for sharing that. I think something that we really need to keep in mind is majority of the time, this is not the case, right? And so for those rare situations where someone is acutely ill and you know, their behavior may be violent, those are the moments to really plan for in terms of your protocol, because majority of the time, as we're going to hear in the discussion panels, that's not the case, and everything works really well. And also the communication between the hospital and the police service is so crucial in those moments. And how do you prioritize, how do you get police to prioritize your call back if the risk level changes in a certain situation? I saw it over here, yeah.
This is an in-the-weeds question around the inter-rise screener.
Okay, I'm going to ask you to hold that till we have a discussion panel later about. Okay.
Functionally, you were saying that police will have it. Will they print it and hand it over?
Yeah, so it depends on the police service who's using it. So I know in London they use an app and they electronically send it. Is that right, Chief Perry? Do you want to talk about it? Yeah, and but in across the OPP, for example, they're still on pen and paper. So it depends on the resources available in your community. Okay, last question. Yes.
So regarding the CTAS and mental health apprehension, in order to facilitate that flow through the emergency, are you advocating or will you be advocating that hospitals develop that task for police as well?
So again, this is where the police hospital committee in your community is so important, because they need to go through what are the typical cases you're seeing in the ER, and how does CTAS, which is the crisis, yeah, thank you, Canadian Triage and Acuity Scale, CTAS, how CTAS is applied in your hospital. And this is where that conversation is so important, right? What we generally recommend is that all acuity being equal in patients in the emergency room with mental health issues, that you prioritize the police accompanied visitor. Okay, great. Thanks so much, everybody.
Thank you, John, once again for your tireless work in guiding the Police Hospital Transition Task Force and supporting the release of the framework and toolkit. We will now take a shortened break, about 10 minutes. There are refreshments at the top of the auditorium, and we'll see you soon. Thank you. Okay, I think they actually they told us not to put the dials out, so I'll just say that you have amazing accomplishments.
You like that?
Blend between. Yeah, great.
Basically, when we did the low medium gas is.
Okay, I think we'll get started. Welcome back, everyone. We're now going to begin our first panel discussion. Our first panel brings together police and healthcare leaders to share and discuss with us lessons they've learned from implementing police hospital transition protocols in their communities. Dr. Tim Rutledge, CEO of Unity Health Toronto, is our chair for this panel, and he told me not to say a lot about him, so I won't, other than the fact that this is near and dear to his heart. Joining him on stage are Jody Younger, Vice President, Patient Care and Quality at St. Joseph's Healthcare London, Chief Eric Gert of Hamilton Police Service, Diana McDonald, Executive Director of Lanark County Mental Health, and Chief Mark Sanders of the Toronto Police Service. I would love to read each of you their bios and highlight their amazing accomplishments, but that would take all day. So please refer to your program for a detailed bio and a lovely photograph of each, I might say, of each of our distinguished panelists. We will now turn it over to Dr. Rutledge and the panel for their discussion. Thank you.
Thanks, Katie. Hello, everybody. Good morning and welcome to St. Michael's Hospital. Very pleased to be hosting this event. This is a really important event, of course, an educational event, but the launch of a major provincial initiative that I think has the potential to have very significant positive impact. Some of you may know my background's in emergency medicine. I was an emerge physician for 25 years and a chief of an emerge department for a number of those years. And this topic truly is something that I have a fair amount of experience with. When I was chief, certainly lots of meetings with our local leadership and police services to try and smooth this out. I see this as a major quality initiative, quality in all of its realms, not only best possible outcomes, but safety, access to care, equity, efficiency, etc. So I want to congratulate Upala and John and everyone that's had anything to do with this initiative. I know it's been years of work, and now we're going to pivot from planning to execution, and I think all that work will be very much worthwhile. Anyway, you're not here to listen to me, you're here to listen to our panel, who will tell you some of, who will be discussing some of the details of this work and anticipating what will work and what opportunities we have to continue to refine this over time as we implement. One of the things that we're involved with at St. Mike's, as a number of you are, in partnership with Toronto Police Services, is the mobile crisis intervention teams. Each of these teams have a psychiatric nurse and one police officer with specialized training. They're dispatched at the request of first response units, and there are currently 6 MCITs in Toronto. I really think that these police hospital transition protocols will work really well with the MCIT initiatives, and I think that there's an opportunity here for us to provide even better care and in many cases avoid emerge visits altogether. During our panel today, we'll discuss some of the lessons learned in implementing the police hospital transition protocols, and I certainly look forward to hearing from each of our expert panelists on this important topic. So without further ado, let's start. So my first question for the panel, and I'm going to ask each of you to speak about this just for a couple of minutes, is I'd like to hear a little bit about your experience with the police hospital transitions work in your community. So We'll start with Jody and go across.
So thank you, everybody. Just to say, I'm here representing St. Joseph's London in my current role, but St. Joseph's Hamilton is really the work that I'm speaking about today, and the protocol that we will talk a little bit about that we developed back in 2012. Just to say that we have a very strong history with our police services in Hamilton, really from quite some time, but for particular going back to about 21 years when we developed the Crisis Outreach and Support Team, or COAST model, which is a sort of secondary responder model, and we're going to talk about other models down the road. But really that was formulated really at the heart of a tragedy, but that spoke to the need for improving how police officers were able to assess risk in the moment and to work with individuals who have serious and persistent mental illness. So we had this long legacy of working well together, doing joint training together, and also improving at that time how we had conversations at the emergency room door. Although I will say even our COAST team at the time had fairly significant weights in the emergency room. So we're going to talk about that, I think, on the next loop through. But the history and the roots and the trust in each other, I think, was very foundational to our ability to move forward in the next piece that we're going to talk about around transition. So with that, I'm going to hand it over to Chief Kurt, who's probably going to pick it up and go from there.
Thanks, Jody. And yeah, just to, when we get into these change mechanisms, again, this is born out of tragedy, as Jody said. It was the stabbing death of Zachary Antidorm, who's 4 years old, stabbed by a woman with schizophrenia who was a next door neighbor. And obviously something needed to be done. That was the genesis of COAST. Since that time, and I realize there's duplicates and acronyms here. So our COAST is actually in its 25th year, born from that event. And then we've moved on to a couple other components, which I'll get into later. So one is a social navigator program, which really looks at the concurrent disorders, but at a low risk level. COAST for the middle portion, and then mobile crisis rapid response team for the higher end. So that was implemented by our previous chief. Actually, he came up with the idea. I had to do the implementation with the team. But to Jody's point, we've always had a strong relationship, and I was just thinking about it earlier. We've had a long history with the Hamilton Psychiatric Hospital placed in Hamilton. So it's been through the course of time. And even our standing protocol and the committee that oversees this work came out of an event where we had an LOP from the HPH at that time who ended up on a school property, and things didn't go so well. So, we're attenuated to the fact that you've got to make the changes. We'd all like to avoid those tragedies, but often it is the impetus behind it. So it's been this collaborative relationship, not just from the staff and the nurses, but the psychiatrists who are up at the HPH. We've had a long-standing committee. I'll say it's rather informal for high-risk situations where we can do work very quickly, and we have information sharing protocols. The legalities have been looked at, but this is all part of it. So when we got to this form, and I know Ron Hoffman is here in the audience, I don't know where. Ron, back at the top there, was doing work on mental health at the Ontario Police College back in the 90s, and actually he came up with a lexicon for the administrative form, and really what it does is enable our officers to articulate in verbiage that both psychiatrists and the nursing profession understand, that you get a very behavioral-based description of what's happening. So those are just some of the key pieces before we come to the next room.
So thank you for being here. So my name is Diana McDonnell, and I'm from rural Lanark County, which is a geographic area between Ottawa and the Kingston region. We developed our Lanark Lead Team protocol, which you'll see here on the screen, and it really came out of having the opportunity to find out what the COAST model was in the London Hamilton area, as well as the help team model out of Chatham, Kent. So our protocol and working with the rural community has been in place for 15 years, this year coming, and it was really established making sure that we were inclusive not only of our police services and our hospital emergency department, but also the paramedics, the mental health and addiction services, the Schedule I hospitals, our distress line, and children and youth services as well. Being in a large rural area, we don't have the luxury of an urban center where there's many resources that are available within a few miles of each other. Lanark County is a large geographic area, very rural community, and one of the things that we really noticed within developing this model was that we needed to have that level of engagement right at the very beginning. We did not have the same relationships, if you will, with police services because the crisis services of Lanark County actually started in 2001. So we actually then began to have awareness of the models across the urban centers and then developed the lead team protocol in 2005. So the partners that you will see on the list are those that have grown over the years. It is our hospitals, our police services of Lanark, Lanark Mental Health and the addiction services, as well as Distress Line, because we wanted to ensure that there was something that was more available 24/7, but our crisis response services were not available to the hospitals or the police on a 24/7 model. So what we wanted to do is incorporate partnerships and understanding of how we all work collectively together to ensure if a person came into contact with the police or the hospital or mental health services, that we had a forum in being able to talk to one another and to develop a protocol that had meaning. And I think Upala talked about this morning that we really need to ensure the ongoing engagement within a protocol framework as well as a training. So you'll hear more about that, but that's how we actually got started.
Great, thank you. And so, I mean, from a Toronto landscape, our relationship is good. There are and always will be room for improvement, but it was primarily out of necessity. So if you look at our calls to service right now, we're close to 16,000 calls to service when we talk about dealing with people in crisis. We've already apprehended close to 5,000. So the volume is what is the driver to make sure that those relationships are necessary. When we look at how we have policed and where we're going to and what we're trying to go to, it's refreshing because first and foremost, I think government is starting to get it because we're now seeing multiple agencies at the table, whereas before, when we're having this discussion, it would be one minister, one discussion, and the other ministers would not be in the room. And so the Ontario Association of Chiefs of Police, we've spoke quite a bit about this discussion and the importance, if we're going to get it right, that collaborative piece is going to be the most essential tool. We can't just do it alone on officers with great intentions doing their job. So when law enforcement tends to be the primary or the number one de facto resource that attends calls for people in crisis, then there is something that is flawed. The city is growing vertically. I'm seeing a lot of buildings getting knocked down. I'm not seeing crisis centers built, but I'm seeing a lot of condos being built. So where we need to go, I think is what the bigger picture is in this room, and hopefully if we have the right stakeholders here, we can start that proper conversation with the right people so that we can actually move this thing in the right direction.
Perhaps I'll ask each of our panelists once again to spend a little bit more time speaking about how the relationship between police services and hospitals have evolved with this work from sort of before we started working together on this initiative to current state.
So coincidental to the work that Nicola was talking about earlier in 2012, in Hamilton, then Chief Glenn DeCare called a meeting with Dr. David Higgins, who was our CEO of St. Joseph's Healthcare until very recently when he retired. And he invited me along as the leader responsible at that time for our mental health services. And the conversation really was about a report that Hamilton Police had done in 2011 that looked at the amount of hours that police officers had spent waiting. And I know when Upala put the slide up and you saw that the pre was 2 hours and the post was a little over an hour, you probably thought, 2 hours? That's not so bad, right? That's not a bad wait in an emergency room. And that probably speaks to our inner voice around emergency room wait times. But in fact, what it really equated to was about 3 FTEs of a police officer 24/7. So really, you know, the burning platform was around and we heard over the community years, it's growing higher than that. So really the question was, were we willing to look at this with them? And we said, yes, we are. We're absolutely willing for all the right principles that we talked about and Upala talked about, the stigma related to individuals waiting, the use of police resources in that way when really we wanted them out in the community and doing their good work. And for all of those good reasons, we said yes. And we convened a group of individuals that had a strong representation from frontline officers, crisis officers, our frontline staff, emergency room triage, psychiatrists, residents, and we really treated it like a quality improvement question, right? What are the tests of change that we can do to improve, to sort of chop down this time? What are the fundamental issues? And we did chop away at a few things. We created an MOU, some of which informed what's in the toolkit around how we work together. We had lead people who were paying attention to on the policing side and the hospital side. We identified that all acuity being equal, if we put a sticker on the chart that said with police, that should be treated with priority. We dealt with our triage criteria, trying to up the language around triage and mental health crisis. But at the end of the day, that sort of inched the ruler a little bit. We'd shave 10 or 15 minutes off, but it really didn't get us where we wanted to go. And when it really came down to it was the fundamental question that many of you asked in the question and answer was actually, do police have to stick around? Do they have to stay? And if you'd asked anybody in our working group around the table, it was an absolutely firm 100% belief that they had to stay until a form was issued. That was the belief. And so we kind of asked the question, why do we believe that to be true? If you read the letter of the language, it's not so clear as we all think it is. And at that time, we had our own legal opinion, and it was nice to have it confirmed by the multiple legal opinions through this process. But the bottom line was there was no case either way to say police had to stay. There was no case law that said that had to be. And so what we decided was, well, let's look at this question and dive in. What will help us make a decision? What for the nursing staff on the front line, for the officers on the front line, will help you make a decision as to whether you need to stay? What's the risk? And from that was born the form that is that last step in the hierarchy of the handover, the idea of how can we, in language that both police officers understand and our frontline nurses understand, how can we speak that language together to identify, assess, and have a conversation about risk? And that, implementing that form, it took us probably about 30 days to trial it, right? We just literally had versions of it in the emergency room, and we would tweak it, and officers would put Post-it notes on it. But when we got it down to about one page and we fully implemented, it was about July of 2012 at that point, our average turnover time dropped from that original 2 hours. It was 125 minutes, I think, was the average, and close to 4-hour 90th percentile performance. It dropped immediately down to that 85, and then over the intervening years, it's actually dropped down below and below. It got down to just under an hour just before I changed roles to go to London. It's probably, yeah, as these do, but I don't think it's gone as bad as it started. Excellent. And really that was the game changer for us. And the really interesting thing, and this is going to be my nice handover point now, is that as we sat around that table together and we had a collaborative process, including go-to people when things didn't go like they should, we started to look at the data coming in. So we started collecting the data to say, okay, what percent, how many forms get filled in, how many were incomplete, let's find out why they're incomplete. But we also started to look at the data of individuals coming into hospital with police. And honestly, for the vast majority, about 65% in a very steady way, were deemed low risk on that form. And that really led us to the question, why are so many individuals who are really low risk coming into an emergency room for care for psychiatric crisis? We had other pieces in our community, but one of the things we were missing was a first responder model that actually understood mental health crisis and could utilize resources differently. And that's what led to the development of the Mobile Crisis Rapid Response Team. So I'm gonna only say one other thing that's I hope it doesn't steal any of your thunder, but just to say that when we implemented that model, and Chief Gert's gonna speak to it, we actually reduced across the region a range between 60 and 85% of low-risk individuals coming to the emergency room in doing that. So now I'm gonna pass it over. Yeah.
Good to go, Tim, thanks.
Yeah.
And thank you for that lead in, Jody. So really it's been kind of a two-prong approach. One, how can you do it more efficiently and save dough? Because we're all interested in that and cross-sectoral. And the second is how can you make the experience better for the client? So it's client-based. So really the two parts that emerged from that working group, and I mentioned earlier, was a social navigator program. Very low risk. It can be the concurrent disorders, poverty, housing, mental health, and addictions. And they call 911 because that's how you know who to call. And we respond, whether it's EMS, ourselves, or fire. And often they end up in the emerge, but really don't need to be there. So we actually instituted through a funding model that had to be patchwork for many years. A social navigator has actually got her master's degree in public health, and she navigates people to the appropriate resource. So you have it's Gladwell's outliers. You have those high percentage of people who use that ton of resources. So really, it can be as simple as, and I remember the presentation we did at the Police Service Board, and so he said, well, how does it work? And the social navigator said, well, my client doesn't have a calendar, doesn't have a phone, wants to go to the appointment, truly, just doesn't know how to do it. And they kind of went, oh. So that's the low-end risk of the continuum. So that's a part of it. Then you got COAST in the middle, which is, again, a plainclothes officer to de-escalate with a nurse at that time. And then the evolution was a mobile crisis rapid response team, which was life-threatening situations to themselves or others. So definitely going down the Section 17 route, potentially. And it had a mental health worker teamed up with a fully equipped officer, all the use of force option. And we were one of the first in Canada to fully deploy conducted energy weapons across our front line. And the obvious idea is we don't want to get there, but if we're at that level of force, we want something that's less than lethal. Because we've read all the coroner's inquests. They keep saying you need to deploy CWs, you need to have more options, you need to do a de-escalation. So it was already there. So one of the metrics when you're looking at how do you sell it, and Jody's being quite humble here in terms of the mechanics, Lynn came in and funded it as a pilot to the $2.5 million, continuing. We eventually got the board to dedicate 5 positions to it. But when you look at the metrics, our apprehension rate by frontline officers who are actually CIT trained, crisis intervention trained, was about 74% of the time. We're currently running at about between 14 and 18% of the time when mobile crisis rapid goes out and deploys. That affects all of us. So the client is not coming in. The mental health worker can use their skills. We're de-escalating. Not that they always turn out. We've had it in our jurisdiction too. And then the hospitals are not as clogged. That frees up my officers out for the street to do all that other work. When you talk about, and we thought we'd come in maybe 40% as a really bold target, to come in at 14 to 18% consistently now over the last 2 years, you can see the efficacy of the program. Keeping in mind, we're in an urban center. It's much more different in a rural center. I'm not saying it isn't. And again, we don't deploy 24/7. I'd like to, and I keep begging the ministry, give me a 13, please. But we are deploying pretty much 18 hours a day with coverage for the bulk time, because we look at the metrics. And again, back to the concurrent disorders, they're all there. But certainly addictions issue, and I was just talking to Jody before I started, because I know the growth both of opioids and meth. Alcohol is still our leading issue for people self-medicating or whatever else is going on. So it requires a fulsome response. We think along that continuum, we've embedded actually in our community mobilization division a person in crisis unit. So we're making those connections out to the community. We have training on dementia and the elderly, because obviously a huge growing sector. We also have training for specific mental health issues from practitioners. And I did talk to Jennifer when I got here. Our chief established a standing committee on mental health with people with lived experience. We think that's so important. Our problem is they have oath of confidentiality for that committee, because of course they want to have comfort, and I revisited it when I became chief. They still want that. So I can't really talk a lot about the work they do there, other than that it's a standing committee to examine our response. Over you.
So I'm envious, thinking about the money that you've gotten from the ministry, so I'm going to be open about that.
Okay.
So just in relation to Lanark, one of the things that certainly has been a challenge for us is how do we reduce the silos in a large rural area. And one of the ways was how we were going to start our engagement, and starting out with a lead team protocol and figuring out who needs to be at the table and how we're going to go about implementing this. So I think it's really important that you have to have the leadership from the top. You have to engage the CEOs of the hospital. You have to have the chiefs of police. You have to have the detachment commanders to be on board with this, and to have a shared mission and a shared vision as to what you want to do in a protocol response and how you want to develop that in your community. We did not have a mobile crisis team, if you will. Our nurses were deployed, though, to our community local hospitals to be available to the emergency department. So in Lanark County, we actually have 2 or 3 local hospitals, but one that has 2 emergency department sites. And one of the things that we heard from physicians and certainly from police, when they brought someone to the emergency, there wasn't a mental health worker that was available to do an assessment in the emergency department. So one of the things that we did as an organization was include registered psychiatric nurses and social workers on site at the local hospital. So when police did bring someone in through the emergency department that was apprehended under the Mental Health Act, or if the person went in voluntarily and they were in a mental health distress, that a member of the crisis team could be there and actually do that mental health assessment. They were actually part of the triage process with the physician and the triage nurses. And what we found were that many times people coming into the emergency department, there were assumptions made about why they were there. They may present with physical symptoms, but there was a mental health related issue that was happening as well, and nobody was picking that up. So with having mental health workers there, it helped to reduce the stigma for the person coming in that may be in handcuffs with police. It helped police to understand that there was a worker there that could do that level of assessment. And it also reassured the patient or the client that they were going to get much more responsive services, and it was going to be something that was done in a very collaborative manner. We had not had crisis services that was available 24/7. We had on-call availability. And one of the things, certainly in the last 10 years, myself and Derek Needham, who is the inspector with the Lanark OPP, really wanted to pursue getting funding and implement registered nurses being within the police services. So as recently as August of last year, we were able to get a registered nurse through Proceeds and Crime Grant funding. We weren't as fortunate to get LIN funding to support us, even though we had put proposals forward in the Southeast to say, we have evidence to show the number of calls that police are getting, we have evidence to show the number of calls that our staff are getting, and we have evidence to show that we need to do something better than what we're doing in our own community. So we were very fortunate to get funding for a full-time registered nurse to be implemented within the Lanark OPP, which started last August. And also the Smiths Falls Police Services were able to get some funding through criminal injuries to have a nurse there 3 days a week. Most recently, we did receive some funding through the Champlain LIN for the Rapid Mobile Response Model. So that certainly seems to be driven from the ministry, which is a good news story for us in rural Lanark County to say, finally, we're having data and analysis and a listening ear to be able to implement having that psychiatric mental health nurse available with the police services. So when the 911 call is made, the police will respond. They go out in uniform to that call, and then our registered nurse will meet the officer at that point of contact with the person that's in a mental health crisis. What we're finding is many folks that had never had mental health services are now coming to us. They never had any service provided to them because either they didn't want it or they didn't know how to access it. In rural Lanark County, one of the hugest issues that we face is lack of transportation, unemployment. So for many individuals that live in the remote areas, unless we have services that are in some of those smaller towns and smaller communities, there will not be access to mental health service, and there will not be that support. So for us, it's really about ensuring that we're communicating, sharing information, working really collaboratively together, and looking how we're going to make things better within our community. And it's really taken a collective approach in doing that and building those relationships and having those trust between the hospitals, police services, paramedics, and mental health workers. So we're excited as to where we're going to get to, but we haven't gotten as far as you have in your urban centers. But if you can help us to get funding, that would be really awesome. So I'll just get that plug in. Thank you. Yeah, okay, that's great.
So
we'll work together.
I think the finish line for all of us is the same. I will say the Toronto experience, I think what we've put at the forefront is the client first and foremost. So right down to the officers and how we hire, the training. We've added a third full day of training to every member of the service, which speaks to dealing with people in crisis and dealing with community engagement. So having that allows the opportunity for that connect with compassion piece, and which are points that we spoke on, and stigmatization, all of those things, and incorporated in training. We will have people with lived experience that have that opportunity of giving us that fulsome version of how we can maximize our roles when we're in those particular situations. But when we talk about the technical structure build-up, we have a host of different committees. The chair and the police board have had a strong working relationship with the mental health agencies, multi organizations at the table, speaking their truths as to what we can do to become better at what we need to do. And Jennifer, I've had opportunity of sitting across from her. We don't necessarily agree with one another in issues, but we are in a platform where we have to listen to one another, and it's what you take away which becomes important. We also celebrate the fact that those core functions, we've added an award which deals strictly with de-escalation, so that our officers can see that we're not just out there rewarding people for bravery and all of those other elements, but that connecting with compassion piece. And so it sends a loud message when other peers are seeing that and understanding where we're going as an organization. With the mobile crisis teams that we have out, they are tremendous with helping us identify some of the cases where the hospital might not be the first resource to go to. And so they act as a triage in helping for those other aspects that can, other entities that can take the leadership role or the ownership role rather than us taking that ownership role. And we also work with the city when it comes to the situational tables. The situational tables give us a good opportunity for finding the right agency to take that ownership role, and we get maximum results. And I know at the situational table, we have, I think it's like a 75% success rate. So we still have a lot of moving parts that we have now that we never had before. So we're trying to move in that right direction, doing continuous world research to see what are the best practices out there, what are the best tools right now to help the frontline police officers, but also to help people collectively. And it's an ongoing, I mean, it never stops. And I'm sure, Eric, you have that same mindset too, where if there's something out there that is better, that can help us perform to our better roles when it comes to dealing with people in crisis, we're always open and looking for it. So I guess these discussions really compel you to stay open and to do a lot more listening so that you can figure out what you can do in those moments that do occur.
Thank you. Now I have a specific question for each of our panelists, and I'm going to start with you, Jody. So talk to us a little bit about the biggest challenges you faced in implementing the protocol. How did you address those challenges? And maybe talk to us a little bit about getting buy-in from staff, from your staff.
Yeah, and just it's actually a great segue to speak about engagement because, and I'm sorry if I missed this when I was talking about who was on our working group, but of course we also had individuals with lived experience and caregivers as part of informing the process. And so one of the challenges was it was interesting because when we enacted the protocol, it really shifted the dynamic in when individuals arrived to the emergency room, both from the client perspective and also from the police officer perspective. I remember because the leaders, as leaders, we were sort of, staying in the department a little more when we were first rolling this out. And I was walking past the emergency room and two officers were walking out and one said to the other, "Is that it?" The other one said, "Yeah, I guess we don't have time for a coffee now." And off they went, right? And so there was a culture, a bit of waiting, I will say. That
sounds like a complaint of getting management, but anyway, go ahead.
Not at all, not at all. Just the reality. Yeah, the Timmy's line it would be a tag team, right? And as well for our clients, right? Because they were used to this process and it changed for them. And so it was a conversation with our clients about why we were doing this, how we could support, individuals in a different way, how we could have the conversation around with police leaving, which was a really critical part to the protocol. The two other challenges really got into the logistics, I think, of the questions that we had earlier. And one was really what the nursing staff said, fine, if police officers leave, what happens if the person becomes more unwell, if the risk increases, what happens then? And so part of that working group commitment to each other was that officers would prioritize a return to hospital. And I'm going to say I just checked in with the leadership there now, and so I can say, in complete openness that between when we started in 2012 and now, there's been a handful of times where that's needed to happen. So I think that's the greatest fear, but it's actually the lowest probability. Because when you do a good communication and handover, the risk reduces. And for individuals who are high risk, really unwell, those individuals are a CTAS 1, right? They need to be seen quickly. You shouldn't be sitting around waiting while things escalate. That individual's in severe crisis and distress and needs help. So I think it is changing that conversation around risk, and really I think staff were reassured. And honestly, a couple of the times when we did have to call officers back, it's because the handover didn't go so well. The communication wasn't there. It wasn't that the information that was communicated was incorrect. And I'd say the other thing was this whole idea of low, medium, high risk. Low is fairly easy. Officer leaves. High is fairly easy. Officer stays, and that's a C-test 1 or 2. This is a high priority individual. The moderate group, as you can imagine, is sort of a group that can be that gray zone. I think somebody said that, a gray zone. And so the nurses would say, well, what if the officer and we disagree? So we made a commitment that if there was a disagreement, the officer stays. And feed that back to the working group, and we'll look at why the disagreement was there, because maybe we weren't clear on a criteria or it's something that we need to inform the process. But the bottom line is the officer stays. And what that did was it took away any potential at the front line, any potential discrepancy or battle, if you will. And it just made the rule really clear, but then it allowed us to address it after the fact. So those are a couple of examples.
Jody, Chief Gert, basically the same questions, challenges you faced and getting buy-in from your staff.
Yeah, so a slightly different viewpoint, but I think your key piece, Jody, is the empathy portion. First of all, I would never want to be a triage nurse. It just wouldn't. You've got the physical ailments, you've got the mental health issues, you've got all the things that happen there. And when I talk about empathy, it's kind of like when our road staff sergeants or sergeants communicate with communications, because you aren't sitting in the communications section watching what's going on. Similarly, you're not in the triage that night seeing what's rolling in the door. So that setting up the middle manager protocol, they talk to each other, and often you get, and this is always my response in training that I aim for, somebody sits in the audience and goes, oh, didn't know that. But when you have that perspective, it really helps. I think relative to change, and Chief Saunders mentioned it, our newer officers are looking for something better. It's not status quo. They examine it with the critical eye and they say, this isn't working, like there's got to be a better way. So when the change was implemented, we didn't have a lot of hurdles because they kind of said, yeah, that makes sense intuitively. You should do that way. So I didn't see a huge buy-in issue. I didn't see a huge education piece about the utility of it, because we would often hear, we've got 8 officers sitting on a Saturday night where the domestics are rocking and rolling and everything else is going on, and I'm sitting here. So from both perspectives, where we're not clogging up the ERs unnecessarily, back to the Chief's point, the client is the center of it. They're not going as often. When they go, it's quicker. It's just a better experience for that, and we all profit from it. So I don't think there was really aversion to change. To your last point, Chief Saunders, they're still looking for betterment, which we are too. Not quite sure what that is, particularly in my standing committee right now is really trying to disentangle the whole concurrent disorders. What's the approach? Who does what agency? And I've often talked about it in policing, and it sounds like you're stepping back from responsibility, but you're stepping back to lead, because other agencies have much better approaches to things. When it's always enforcement based and everything looks like a hammer or a nail and you're the hammer, it's not the better approach. And I was just talking again in terms of prevention, those type of things. I see Lisa Longworth up in the audience. We did a ton of work in youth engagement around prevention. One of the things that's troubling me in our metrics right now is both suicidal ideation in kids, but also how young they're coming in at. Some are 6 and 7, and you're like, how does that happen? So that's on the horizon. Don't know the best approach. We got the current concurrent disorders. Change process went okay, but now we're looking for the next step, and I'm not quite sure what that is yet, but I look forward to really seeing the solution come out of other agencies who know or have better approaches to it that don't involve kind of an enforcement strategy. And we'll step back to lead in that part. We're not going to abdicate, but we're going to look for more creative solutions from other sectors. And to your last point, this will finish with, this multi-sectoral, particularly at the government level, and I can't remember it happening either, we're sitting with 2 or 3 ministers in a room talking about the same things where they say, we need to work together. And you're like, and we've been past the silos, I think, in most of our communities. We understand the interrelationship. It's nice to see it happening in government, and this is a very tangible result of that. So again, John, and you both led this initiative. It's fantastic, and so we look forward to what's on the horizon. So thanks.
Or sorry, Diana. Sorry about that, Diana. Diana, we'd love to hear some perspectives from you, particularly as this applies to the rural area. And perhaps you could talk to us about additional factors that need to be considered in the rural area and specific challenges faced.
So I think the rural area, probably some of the greatest challenges, as I've mentioned earlier, is around the transportation and the remote areas. We have a large geographic area, so for staff to go to community or out into the community, it could be an hour's drive in one direction, an hour's drive in another direction. So the ability to have staff or access to points in different parts of the rural area is very important. I think one of the other challenges that we really needed to pay attention to was what families and clients were experiencing. They would tell us, that if they went to the emergency department, they could feel that they were being stigmatized against because they came in with a mental health concern. One of the concerns they had is if they were apprehended by police, why did they have to be handcuffed? Why did somebody have to be transported in the back of a police cruiser from a local emergency department to a Schedule I facility? These were some of the greatest challenges that we had. And for the staff that were doing the crisis response, what does that really mean if they started to work with police and the hospitals? Because coming from a mental health perspective or a health care model and going and understanding more about policing is a very different framework of knowledge. So the greatest opportunity that we had was to bring everybody together and start to talk about what is our common language when we're seeing individuals experiencing a mental health crisis or needing mental health support. So one of the things that was really important with the protocol was making sure that we reviewed that on a very regular basis, and we looked at things that were changing within it. So when we actually started, we had developed what was called a Lanark Lead Teen referral form, which included some of the information, certainly that Ron has included into the Inter-RI form. There was a lot of that that was really important for us to have. What were the observations from a policing eyes and going into a person's home that we would not know what that looked like by the time they brought that person to the emergency department? So what happens in the community when there's a first call from 911 and police respond is very different from what happens when you bring that person to the emergency department and an assessment is done there. We weren't having any of the history to say what actually called the police, why were the police referred, why did that person go into crisis, what was their home environment like? And having the observations or the referral that the police could do, and particularly now the Inter-RI BMHS form gives us those observations and history that we would not be aware of. So really getting the nursing staff, the physicians, the police, the mental health workers to really start to use similar language, and that's what the training that we do on an annual basis is really about. It's having that common language associated with what do mental health disorders look like, what are some of the symptoms, what are some of the behaviors, and how are some of the response strategies developed so that not anyone is really being stigmatized, that it's increasing the awareness of how we look at folks that may be in a mental health crisis, but there may be other underlying issues that are happening that we were not aware of. I think the other part that's a challenge is ensuring that the protocol is a living, breathing document. It's like everything else. We can all have pieces of paper, and we may never look at them again once a protocol is in place. So one of the greatest things that I feel that we've needed is to have a liaison person between the hospitals, the police services, the paramedics, mental health workers to say, we are the coordinators of this protocol and we all are buying into the protocol. We need to be able to communicate what the protocol means to all of the partners that are involved because there's always a change in staff. And then you start all over again. So it's really important to ensure that everybody's very clear about what our responsibilities are. It's also about making sure that we're involving families and care providers so that they know what's happening and what's changing in the community so they can also engage in that process. And peer support is huge. I think one of the greatest things that we've added into our work with our protocols and the relationship is peer support, family wrap is really an integral part of us always hearing and understanding from not only the client but their family perspective, what is it really like when they're experiencing a mental health concern, and what are we really doing as healthcare providers and policing services to ensure that that person is getting the best quality of care that they can have. So I think it's a challenge for all of us. I think it's a shared responsibility, and that if we're all engaged in that same purpose, I think the success of that is going to be something that will take us in years to come.
Thank you, Diana. Chief Saunders, perhaps I can ask you to speak a little bit about your experience with mobile crisis intervention teams, and specifically, what do you see as the opportunities with these teams and particular challenges? And perhaps I'll provide some perspectives on this after your anything I might have to supplement. But mobile crisis intervention teams.
We now have 10. So ideally, each district has one. And the hours that they cover are the most time if need, which covers from 11 a.m. to about 10 p.m. The benefit, what we've seen is the benefit of the not getting that secondary call or that third call. So when we do deploy our mobile crisis teams, they have the opportunity of spending a lot of time to look at the individual needs of that particular client and ensuring that the proper facilitation of whatever is needed is provided. So it's a lot more holistic, it's a lot more sustainable, which is what we're finding. And but the downside to it is a partnership between law enforcement and the health industry. And when you talk about the health right now, there's a shortage everywhere. And so providing the nurses is one of our problems that we have right now. So the concept sounds great. The resourcing is what our issue is right now. And then looking at it from I'm trying to look at the finish line. And the funds need to be put towards those centers of excellence. And you can keep getting more police officers to be a part of this role, and we'll be there. But there is a bigger picture. There are opportunities to start that conversation for what really needs to be put in place, what really needs to be holistic, sustainable, and necessary. The capacity issues that we have, as I stated earlier, we're apprehending close to 30 people a day, apprehending. So the capacity is at an all-time high. Our numbers have not gone down in 12 years, and we're going to 100 calls a day. So for me to just keep adding more into that budget line for that role, incredibly necessary, but we have to collectively look at what the better solutions are out there that can really solve the core of what's happening in our city.
Great points. Perhaps I'll just add a couple of things. I do see these as huge opportunities in our system. What's happening in Ontario now is all about providing a more robust, less siloed system, providing better care to those that we serve. And I see these teams as a huge quality improvement, keeping people in the community where possible and providing better care, supported by our partners in police services. I just have a couple of thoughts on it, and then our thoughts are very aligned. One was, I think it would be great for us to do some evaluation of these teams, find out what really works, and what we could potentially do better and more efficiently with the best possible resources. And then the other is, I really do see I think what we've identified in all of this work is really an unmet need. We could do so much better. At the end of the day, probably the system would be more efficient and more sustainable. But I think really the opportunity is to actually expand this work and actually make it more available than just the hours that it's currently functioning. But that takes resources and really great partnerships and evaluation. So I've asked for a little bit of extra time because this is such an important opportunity, and so I'm gonna suggest that we have a little bit of time for questions and answers from the audience. What I am going to ask is, for the benefit of those watching online, that questions get asked on the microphones, if you don't mind. So at this point, I'd like to open it up to the audience for questions. And we have someone approaching the microphone. No? Kibosh on the questions by asking you to approach the mic. I'll tell you, all right, then another option would be to shout out your question really well, and then I'll ask the people at the front who you direct them to repeat the question. Don't all ask your questions at the same time. I think the panel is the wrong. Does anybody from the, okay, we have a question. Yes. Okay, thank you.
Hope it's not about where we get the money from, just us.
My question is for, around a comment that Diane made, because from the rural perspective, I'm from Saugeen Shores up near Owen Sound, and obviously we have Owen Sound Police represented here also. You mentioned a liaison officer, which I think is a really good idea, where you have somebody who is coordinating the efforts. And where does that liaison officer come from? Does it come from one of those disciplines, or do you nominate a person, and is that a full-time position? And once again, it comes back to how do you fund something like that?
You're asking me that question? Yes. Okay. So one of the things with the lead team protocol, I've been very fortunate to have a coordinator work with me over the years that was from the Lanark OPP. And the other part that has happened since we have now implemented the nurse being within the detachment, one of the officers has actually been designated to be that liaison, the mental health officer with the nurses as well as the community partners. So I think it's really key. We've done the same thing with the Smiths Falls Police Services because it's that point person that helps to facilitate whether the referrals are coming to us, the follow-up if somebody needs to be seen in the community, and if there's any changes that need to happen as far as how the protocol's been the process of the protocol and the process of the referrals. The other part that's really important is the leadership within the organization. So myself as the former executive director, because I retired last Friday, but to be able to have that linkage at senior leadership and the same within the hospitals, the CEO, so that we all work really well together and we really have formed those relationships over the years, and that's what makes it successful.
Yeah, and I've just got a quick comment because we actually wrestled with this. We wanted 5 frontline positions, and we wrestled with should we have an administrative acting sergeant in the role or not. And really the preference was to have them out in the field. We've actually found great utility in having that person dedicated as a coordinator of training, as a liaison for whatever the agency is to work through those dicey issues, to have a standardized approach. I was actually adverse to it, but it come to realize that we actually needed that, and not that I wanted to bulk it up with more administrative positions, but there's great utility in that, particularly with having a contact for the organization. And it's always the 2 to 3% of the difficult things. The decisions that are 90-10, you can pretty much make those. The 51-49% decisions, then we want somebody with that skill set to actually do it. So that's where we went.
Ours was embedded into certain roles. So at the more senior leader level to sort of the detective sergeant level comparator within police. That was myself in that role. And then I had a couple of officers who cycled through that. And just to validate the importance of having those more, you're at the front line kind of engaged, both at our clinical leadership and then the officers, because really those were the folks who lived the day-to-day with the front line and who really understood some of the critical issues and could feed up and down any changes that need to be made, but they weren't dedicated positions. For us, it was, many people in this room know Terry McGurk. I mean, he was sort of the creator of COAST and CERT and has led, he retired a few years ago, but really led a lot of crisis modeling in Ontario. And because he had the respect, I think, from police and clinical world, he was able to sort of, I almost call him like knowledge translate, right? The questions and the issues so that both worlds kind of understood and we could come to resolution.
We're going to take 2 more questions. So.
Common language. My question is, we live such in a multicultural. What about language barriers? Several translators not for every language. So I was just wondering if there's a delay on a translator, would that delay the entire process if there's a crisis? So what would be the next step?
The question is around language barriers. So just so you, for your understanding, we're in a very rural area that's very much about sort of English speaking. There's not a lot of Francophones, so that's not something that we've had to actually address. Some of the other areas certainly do include things around not only Indigenous community, but also French language and others, so they've utilized some of that. When I was talking about language, some of it was around understanding what mental illness was. and being able to understand what signs and symptoms are and what behaviors are, so that if a police officer is seeing someone when they're doing a response, it may be that the person may appear that they're under the influence of maybe alcohol or substance abuse, but they could have some other physical health issues happening, and being able to recognize some of those factors as well, not to be making assumptions. And then the inter-eye screener really helps understanding what mental health symptoms can be. So for officers to be able to talk about this person may be experiencing hallucinations or delusions, or they may have suicidal thoughts or behaviors. So really being able to not just touch the surface, but go beyond the surface and ask further questions. And the same with the emergency room nurses, not to always just make assumptions that a person can be coming in with a physical related illness. There may be some emotional factors or other distressors that are happening as well. So part of our training really looks at what types of mental health disorders there are, how you might recognize that, and then being able to share that between whether it's paramedics, police, nursing staff, or physicians, so that we're all very clear about how we're communicating with one another as well. Does that answer your question?
Right behind you.
You mentioned researching. I just want to make a comment on research design. It's challenging to assess MCIT if the contact point is the staff of MCIT, because it creates a biased sample. So there needs to be a way that independent researchers can contact the clients of MCIT. And there's also some question about what comparison group to use. And we surveyed people before the development of MCITs in Toronto, and the preference was as much as possible for community-based crisis services rather than hospital or police-based crisis services. And I agree with Chief Saunders about how we have to look at expanding alternatives in many different dimensions.
It's a great question. Jordy, you want to?
I think Chief Gray talked a little bit in London around the development through the Canadian, or actually maybe it was UPLA, the Canadian Mental Health Association's crisis service there, and that is a community-based, essentially a walk-in service if that's what you want. But as well, officers responding or mobile crisis responding can also support individuals in accessing care there versus the hospital. And I know they're working now on a overnight capability there as well, if you need a short stay when you're in crisis. And I know the other piece that's being worked on is allowing paramedics to bring folks there who are in crisis, which would be a really excellent enhancement to our system. That's sort of the third arm we haven't talked at all about, but it's another piece we need to bring together around our community paramedics. So absolutely agree, because the answers for the majority of individuals who are experiencing a crisis do not lay in the hospital. Certainly mobile crisis taught us that. The vast majority of individuals need other kinds of supports, both in the moment, maybe within the next 24 hours after the crisis, which is when you have a nice network of services built up, you can do that, a follow-up visit or phone call. And there are a small proportion of individuals who do need hospital and emergency room, but that is absolutely the minority and not the majority. And our system, I think, historically has been really built on that 90-10 rule, but we're treating 10% to the 90%, and that's really not what's needed. So 100% agree.
Folks, we've come, oh, go ahead. Just.
Really, our social navigator streams to most of those community organizations, and that's lower risk. Generally, when we're called, as I say, it's either life-threatening or it's post-incident, which is ghost. But we can stream all the way down from MCERT right to social navigator if that's the appropriate contact. So we really are trying to broaden out those other connections. And to your point, it was like my last closing point. There's many other organizations and people equipped to deal with it in a far better way for the client. So we try and stream it if we can. It's not just a financial decision, it's also quality of service decision.
Well, folks, we've run out of time. I know we did have one more question, but I'll ask is that there would probably be an opportunity afterwards to ask panelists questions directly. Sorry about that, but we have gone a bit over time. That said, this was a really valuable panel. I do want to thank the Human Services Justice Coordinating Committee for organizing this panel and this event, and thank you to each of our panelists. So please join me in thanking Jody Younger, Chief Eric Gert, Diana McDowell, and Chief Mark Sanders.
So once again, thank you to all our panel members and Dr. Rutledge for moderating the discussion. I'd like to continue the conversation around police hospital transitions by inviting the new members of the second discussion panel to the stage, please.
Thanks. Yeah. Water. I'm fine. You're fine.
Wonderful. So this panel will be discussing more practical key considerations for implementing police hospital transitions, especially around how we share information in these situations. Superintendent Bill Shantler of the London Police Service is our chair for this panel. Joining him on the stage are Brian Beamish, the Information and Privacy Commissioner of Ontario, Commissioner Thomas Carrick of the Ontario Provincial Police, and Brian Davey, the Executive Director of Connex Ontario. Again, please refer to your program for a detailed bio of each of our distinguished panelists. We will now turn it over to the Superintendent Shantler and the panel for the discussion. Thank you.
Thank you, Sarah, for the introductions, and thank you to our esteemed panel members for being here this morning to participate in our discussion related to practical approaches for information sharing that police and hospital staff need to consider to successfully implement police hospital transition protocols in their communities. Just to set the table for our discussions, there are actually two levels of communications and information sharing that's required in order to successfully implement police hospital transition protocols. And that's at the administrative level and also at the frontline level. As we already heard this morning, the Improving Hospital and Transition Framework identifies several key drivers of effective police hospital communications and relationship building at the administrative level, which include first obtaining the endorsement of the Chief of Police or the OPP Detachment Commander and the hospital CEO, because a strong commitment, support, and endorsement from the most senior leaders of the organizations has a cascading effect and encourages all levels of staff across the organizations to establish positive working relationships. The second is to establish a police hospital transition committee to provide leadership and coordination necessary to assess current practices, develop, implement, routinely monitor, and evaluate the effectiveness of the protocol. The third is to develop the protocol and a written agreement that outlines each step in the police hospital emergency department transition, beginning when a police officer apprehends a person under the Mental Health Act, and ending when the person is transferred from the police officer's custody to the hospital emergency department care. The fourth is to provide training on the implementation of the protocol, including the provision of training to all staff who have a role in the protocol. The fifth is implementing the protocol, beginning with an initial testing phase where issues arising from the protocol are identified and necessary corrections made immediately. And finally, to monitor the protocol routinely to ensure that as issues arise from the implementation of the protocol, adjustments are made as needed. The exchange of information between frontline officers and emergency department hospital staff is the critical element to the effective and expedient transfer of a mental health patient from the police custody to hospital care. Indeed, the exchange of information, expedient examination, and expedient decision-making in terms of the hospital taking custody of an individual from the police are legislated within Section 17, 18, and 33 of the Mental Health Act, as well as Section 7.2 of Ontario Regulation 61600. In London, we've established a chain of information and sharing communication between our frontline officers who take an individual into custody under the Mental Health Act and the London Health Sciences Centre Emergency Department who receive these individuals from our officers for involuntary mental health care. Our information sharing process includes, first, our officers utilize the intra-RI brief mental health screener, which uses mental health practitioner terminology and criteria to make an initial assessment of the individual's state of mental health. Next, our officers notify the London Health Sciences Emergency Department through our communication center that they are en route to the hospital with an in-custody mental health patient. Then, using the Health IM computer application, our officers are able to send an electronic copy of the intra-eye brief mental health screener from their cruiser's mobile data terminal to the emergency department, which receives that screening form prior to their arrival at the hospital. And then upon arrival at the hospital, at the emergency department, our officers then meet with the triage nurse and hospital security to exchange information regarding the grounds for the apprehension and any potential security concerns about the individual. Commissioner Beamish, can you tell us what privacy issues do we need to keep in mind with regards to information sharing, and what would you say are the do's and don'ts of information sharing between police officers and hospital staff?
Well, thanks for the question, and I'm very appreciative of the invitation to participate today, and not only to participate in this event, but I'm really pleased that my office was able to be involved in the development of the protocol and the other tools right from the inception. And I want to recognize the good work of Stephen McCammon, who's from our legal branch. Stephen was involved in this work from the inception. Sometimes people are involved in developing new programs, and they get to the end of it and they think, oh, what are we going to do about that, that privacy thing? So it's always a good thing. We always enjoy being involved right from the start to embed the privacy issues and privacy solutions, even more importantly. We have, at the IPC, always recognized the importance of community safety, the importance of law enforcement being able to collect, use, and disclose personal information as required to contribute to community safety and to contribute to the safety and the well-being of individuals in the community. And similarly, we've recognized the importance of the ability of healthcare organizations like hospitals to share personal health information. And we've never taken the approach that somehow privacy should be a barrier to the delivery of necessary health care to individuals. And I think our privacy laws in the province recognize that. It certainly recognizes that there's wide discretion for law enforcement officials to collect information and to share that information for the purposes of community safety, to address health and safety risks within the community relating to specific individuals as well. And similarly, our health privacy law in the province recognizes that healthcare officials and organizations need to be able to share information to deliver healthcare services. But both those laws recognize that there is an importance in protecting the privacy of individuals involved, that those are all laudable goals, but they have to be done in a manner that respects the privacy of the individuals. In other words, it sets a framework for how that information is going to be shared. And I think our laws do that. And I think that the protocol that has been developed does that as well. It recognizes that as the police and hospitals deal with that transition period, they have to respect our privacy laws. And I believe that by adopting this protocol and by providing training to the police and to hospital staff, it will contribute to better communications, better outcomes for the individuals involved, but we'll do that in a way that is respectful of the privacies of the citizens of the province. In terms of do's and don'ts, and I think these are really embedded in the protocol document itself, I think police and hospital staff should share information that's required. If information is required to assist that transition period, share that information to ensure the safety of the individual involved, but don't overshare. One of the principles of privacy legislation is that idea of minimization. Only share the information that's required to achieve the desired purpose. So there's a real need to remember that idea of don't oversharing. And I think there was some discussion about this concept of whether the police should stay until a decision is made on Form 1. And the protocol reflects the idea that if the police do stay, hospital staff should feel empowered to tell the police or share the decision that's being made with them. But if the police do not stay until that decision is made, then the hospital should be seeking the consent of the individual involved if they're going to report back to the police in terms of what the decision was made on the Form 1. And that consent should also should be informed and should be knowledgeable, and those individuals involved should know that if that information is shared back with the police, that it's possible there might be further disclosures. For example, that might be recorded on the CPIC system. Thank you.
Thank you. Commissioner Carrick, my next question is for you, sir. Please tell us about the brief mental health screener that the OPP officers are currently using. What were the challenges with implementing this tool, and how did you address those challenges?
Certainly, thank you. First of all, it's important to note that the OPP has been using the brief mental health screener since 2014. Over the 4 years or plus that it's being used, essentially the big difference it has made with effective communication, helping our officers be able to articulate in a way that provides consistency between the officer and healthcare professionals. I think we have to understand and appreciate from a frontline officer's perspective, what other calls do we attend where the primary objective is to provide medical assistance? We may attend a collision scene or an accident, and we will provide emergency first aid, but then we transition from that into our primary responsibility, which is that of law enforcement. This puts us in a different space where we respond to an incident where the primary objective is to provide medical attention, yet we're left in carriage of that incident and that individual, that client, until there are further supports in place. When we articulate our grounds, they are normally articulated within the confines of the law. So police officers are used to testifying in court, and their objective and their job is to provide the facts and issues that lay out an element of an offense. That does not work when you're looking to provide people with medical attention. And that's where we need the use of a tool like this to help us transition. It breaks it down into two key components. One is the indicators of disordered thought, and the other is the indicators of risk of harm. That allows the officer to be able to lay out in an appropriate way for medical professionals to make an informed decision, minimize the amount of time that officers are spending in the hospital, reduce the risk of escalation while we're waiting to be seen, and also minimize the amount of stigma that's already been talked about when an officer has to sit with a patient waiting for that care to be provided. With respect to challenges, appreciating that we are covering a jurisdiction of over 1 million square kilometers of very rural territory with the OPP. We've got 150 plus detachments. First and foremost, being able to train all of our officers with the use on the tool. I'm very pleased to report that that has been done and has been done for quite some time. Making sure that we are effectively using it. We certainly benefit from Lisa Longworth and her expertise and the constant monitoring of our use of the tool. And again, very pleased to report that in 95% of the cases, the tool is being used, which is important. Chief Saunders and Chief Gert spoke to the impact on police resources that these calls have. I can tell you that in 2018, we responded to almost 19,000 mental health related calls and spent nearly 121,000 hours. That's taking the equivalent of 59 full-time police officers off the street dealing with these matters when they could be dealing with things that are not health issues, things that require an emergency response, thing that requires only matters that the police are trained to perform. So for all intents purposes, this has been an absolutely wonderful tool that has assisted us to continue to build those relationships, get on the same dialogue with our healthcare professionals, and allow us to provide the best possible service to those in crisis.
Thank you, sir. Mr. Davey, my next question is for you. Please tell us about Connects Ontario. How can the resources available through Connex be helpful to both police services and hospital staff?
Good morning. Connects Ontario was born in 1991, originally known as the Drug and Alcohol Registry of Treatment. And our job at that time was to build a database that housed information on all of the funded addiction programs in the province. That database became a critical decision support tool for the OHIP out of province branch back in the early 90s. It's been an evolutionary process. In 1997, the organization was mandated by the Ministry of Health to become the access point for addictions and problem gambling. And at that time, we became a 24/7 public-facing operation with 2 helplines and 2 websites. Mental health was added to the mix in 2005, so we've been the access point for those 3 services since 2005. In April of 2018, we dropped the 3 helplines on the advice of some marketing researchers and the Ministry of Health and rebranded as Connects Ontario. So we now have 1 website, 1-800 number. The old numbers still work, by the way, so we keep getting the calls from the slot machines and so on. However, with going to the 1 number has allowed us to really focus on our branding. And you'll see if you picked up any of our branding materials or marketing materials at the registration table that at the request of the Ministry of Health, we have branded very closely to ontario.ca. So our colors become green. Last fiscal year, our system navigation specialists fielded just under 100,000 contacts. Those over 17,000 were live web chats. So when people come in, we live answer 24/7. When people come in on a call, fair enough. If they come in on a web chat, it's a live interaction that goes on. It's an interesting modality because it does take roughly 3 times as long to deal with a contact with a web chat as it does a telephone call, but it's very popular. The systems navigation specialists to respond to contacts are usually come to us from a background in community mental health or addictions work. They go through an extensive training program with our staff. They're assist trained and they all work toward their Association of Information and Referral qualification, certification. I want to talk a bit about our database. It differs very greatly from databases used by other information referral services such as 211. A program file at 211 would have about 100 data points. A program file at Connects has about 600. We go very, very deep and we're very much aligned with the language and the lexicon used by the Ministry of Health and Long-Term Care. In 2018-19, we generated there were over 20,000 data reports pulled or pushed from our database. So one of the reasons or one of the advantages of going so deep in data is that we could answer the ministry's question, which came out a couple of months ago, when they asked us to identify all the services in the province that use either cognitive behavioral or dialectic behavioral therapeutic approaches or components thereof. It took us 20 minutes to generate that list for them. We have partnership agreements in place with a number of other services. We data share with the Northeast LHIN and the Center for Innovation on Campus Mental Health, which is based out of the CMHA Ontario. One of the partnerships that you can see tangibly on your way home tonight if you ride Via Go or TTC is the one we have with Metrolinx. There are purple and white signs along the tracks with black lettering that say things like, do you need to talk today? How are you feeling today? That's our number, and it's there's a mutual advantage. Metrolinx wanted a number they could use over their whole all their track from Hamilton to Oshawa up to Barrie and through the GTA. And we wanted access to Metrolinx. So the agreement we have in place gives our folks on the phones direct line into the control center at Metrolinx if we get a call from somebody or something that's happening near the tracks or on the tracks. A good example would be a call we took last fall from someone on the platform at Stouffville who, it was about 10 at night, and that person indicated that sometimes they got funny ideas when the trains went by, but didn't indicate they were really in imminent danger of harming themselves. We were able to go into the control center at Metrolinx. They activated their cameras, and they could see that the platform was empty, and they assured us there wouldn't be another train down that line until 6 the following morning. So it's a really neat advantage for us to be able to respond. Direct Connects is a tool that is in use around much of the province. It's an online scheduling tool which is used heavily in Champlain, Lynn, for example. There's a mental health agency there, Rita Wood, which uses that scheduling device. So theoretically, in Ottawa, a police officer can come face to face with someone. They're not sure what they need to do. They can contact Rito, they can contact us, and we can immediately book them into an appointment for that person to be assessed or seen, usually within 2 days, and we can give them all the detail of that appointment. Then about 2 hours after the appointment should have taken place, we loop back with an email to the clinician and basically asking the clinician if the person attended the appointment and what had happened. And if the person didn't attend the appointment, then we can loop back to the police services to say the person didn't attend. So we're coming back to that. I think that's, other than we have a not-for-profit with a provincial board drawn from people that are drawn from all over the province, and one of our board members is Dr. Ron Hoffman.
Thank you, sir. So to wrap up our discussion, may I ask each of you to provide us with a brief overview of the practical tools and resources that your organization offers that can help affect successful police hospital transitions. We'll start with Commissioner Beamish, please.
I guess the most obvious answer to that is the protocol itself. I think that it sets out, particularly I think it's pages 27 to 30, the kinds of considerations that should be taken into account in terms of the disclosure between the police and hospital and feedback after a decision is made on the form. But this tension between the need to provide services to folks and the need to do it in a way that respects privacy is not unique to this situation. Chief Saunders mentioned situation tables, and I'm sure most of you are aware of how those operate. That's the tables across Ontario. They're called situation tables or community hubs, where community groups come together, including the police, to determine how to provide services to high-risk individuals. And it's an area that my office, again, has been really pleased to participate in on how those individuals can receive the appropriate services, but again, in a way that meets the requirements of our privacy laws. And we have provided a lot of guidance in that area. I mentioned Stephen was key on the protocol. He's also traveled the province providing education and training to situation tables themselves. In some ways, on some of these issues, I'm a bit out of sync with some of my provincial colleagues. Situation tables is an area it would have been easy to say, well, you know, I'm not sure you can do that. You're sharing information that's really sensitive, and you shouldn't be doing it. But our view is that there are always solutions to these things, and there's a way to do it properly so that people can get services they need, but in a way that's respectful to them. The other tool that we have developed and released earlier this year addresses questions we get all the time from government organizations who say, when are we allowed to share information proactively with police? And our privacy laws provide a great deal of discretion for organizations to determine that they will share information with police. So we have put out some guidance to say, here are the considerations that you should be looking at if you are making a decision or a determination on whether you will proactively share with police. And here are the situations where you might want to say, well, maybe you better go get a warrant before we make those disclosures. So I think that's some really practical advice to help people address these questions about whether it's okay and consistent with our privacy laws to share information with law enforcement officials.
Thank you. Commissioner Carrick?
Thank you. I think a lot of it has already been addressed by the distinguished panels before and by my colleagues here with me right now. First, it starts with leadership, and with the OPP, there is a defined mental health strategy. And what's unique about the OPP's defined mental health strategy is it's titled Our People, Our Community, focusing on that as police, we are members of the community. We suffer from some of the same mental health crises as members of our community, and that goes to breaking down stigma and ensuring there's access to services and support. It requires us to think differently. So we hear all too often of an absence of funding available to us in the public sector. But we've talked and talked and talked about the time and attention this takes for all of us. And when you truly examine the return on investment by having dedicated staff, and when you dig down and you analyze the data, this is affordable. We can afford to dedicate people to these roles and responsibilities by freeing up the very valuable time of our frontline members to deal with other issues. So it's putting that analytical lens and thinking critically and prioritizing where you are going to invest your resources. And I think some of those are the more strategic approaches that we can take that then allow us to have those practical tools in the field to deliver the best possible service.
Thank you. And just to conclude, Mr. Davey.
These are the areas where Connects Ontario could be of use in the police hospital transition area is at the very front end when the police first come make their initial contact with the individual. Our Direct Connects calendar is could potentially be a great way to help people divert from going to hospital or being arrested. The other piece is on the other end for discharge. We work very closely with Corrections Canada, for example, to assist them in people being released from custody, because what we've learned is a person who's serving in a federal institution knows long in advance when he will be released, but if they're being released to a halfway house, they often don't know until 4:30 in the afternoon if they're going to Sudbury or to Windsor. So Corrections Canada uses us a lot to hurriedly set up supports when they find out at the last minute where that person is going to be. So please keep us in mind. We have a good deal of capacity available, and we would like to partner with anyone who thinks they can use us.
I'd just like to take this opportunity to thank our panelists for sharing their thoughts and knowledge regarding information sharing that police officers and hospital staff need to consider to successfully implement police hospital transition protocols. We are running a few minutes behind, but I will take a few minutes to take questions if there are any from the floor.
Commissioner Carrick, with reference to Mental Health Act apprehension, can you describe or define any challenges that you may have with contacting the local hospital?
Calling it. Yeah, I wouldn't be in a position to speak to that specifically with over 150 detachments. I don't have the
Direct knowledge of specific challenges, only to know that it's got to be a challenge for us in some of our rural and remote communities. Technology is a challenge, so I know many services have looked at the Health IAM application, which is also a very valuable tool. But for us as the OPP, trying to make that technical connection through the internet or through telephone can prove to be a challenge, which is why we rely on the paper base of the Brief Mental Health Screener to help us overcome those technical challenges, because to your point, having that contact in advance may not be something that we're capable of doing.
Thank you.
Thank you. All right, thank you very much.
They didn't get a chance to introduce me.
Many thanks to our second discussion panel and Superintendent Chandler for moderating. And with that, our forum comes to a close. We'd like once more to thank our special guests, Parliamentary Assistant Robin Martin and Solicitor General Sylvia Jones, for opening the day. And we want to thank both of their ministries for their support for the Police Hospital Transition Framework and Toolkit. And thanks once again for the partners on this work, the Provincial HSJCC, the Ontario Hospital Association, Ontario Association of Chiefs of Police, Canadian Mental Health Association Ontario, and all the many people who contributed as part of the Police Hospital Transition Task Force. And I just want to give a shout out to the Provincial Secretariat staff, Tasha, Candice, Joseph, and Christine, without whom we would not have been able to have this event.
And lastly, we'd like to thank all of you for attending and joining us at this forum to learn from one another and mark the release of the Police Hospital Transition Framework and Toolkit. We strongly hope that we have shared today assist police services and hospitals in communities across Ontario in establishing more effective police hospital transitions. These resources will be available online on the HSJCC website. A link is provided in the forum materials you received today and can be easily found on the HSJCC website. We hope you take the opportunity to view these resources as you begin developing, implementing, or refining your own police hospital transition protocols in your communities. And again, thank you for joining us.
Thank you.
Have fun now, eh?